have the oral contraceptive, a patient who has history of bladder cancer, these might be the patient where you must not use it. Rest of the patient, you can use the drug, taking precautions that you might have to use a small dose of diuretic if patient is developing hypertension, or may have to avoid this drug if patient is developing weight gain. But younger patient, insulin resistant, NAFLD, other group indication for hypertension also can be used for injection.
Dr. N.K. Singh, Dr. Arvindo, I think the debate can go on very long. This is a wonderful molecule which comes with a mixed bag with a double S word. In patient selection would be very useful, and deciding which patient needs this molecule. I think we had an excellent debate. Thanks for this.
Thank you, sir. Now I request our chairpersons to present tokens of appreciation to our speakers.
Rahul. Sir.
I now request Dr. Rajiv Chawla to please come up on stage and present token of appreciation to our chairpersons. Moving forward with our next session, which is a panel discussion on diabetes reversal. I now invite our moderator, Dr. DID2022, who is Chief of Endocrinology at Artemis Hospital, to come on stage.
Good afternoon. At the outset, thank you so much, Amitesh, Saurabh, and Amit for inviting me here. Without much ado, I'll invite the panelists who could form my team for discussing about diabetes reversal. Dr. Vijay Patni from Kolkata, Dr. Ashish Degra from Jabalpur, Dr. Abhishek Srivastava, again from Jabalpur. We are late, we have been told that these people will slide, and if they do, they'll come here. I don't want that happening, so let's finish up in time. Suffice to say, all these three authorities in their cities as far as diabetes management goes. Now, let's start from the basics. See, once a patient comes into OPD, the one who mistakes the most in terms of diet and exercise is the first one to ask, can I reverse diabetes? So I reverse diabetes, I become non-diabetic, and I can start behaving again from the world. That obviously does not happen. So I'll start off straight away. Dr. Degra, can I ask you, what actually do you mean when you say reversal of diabetes?
Thank you, sir, and thanks a lot to Amit and Saurabh for inviting me here. And the DID we are being here. So, reversal. Before that, I will ask what is diabetes. So, diabetes is when the A1C goes above 6.5. So, reversal is opposite of that. You bring the A1C below 6.5 and you are maintaining it without any support, without any medication, that is reversal. But now the ADA 2022 has permitted this this term because there were many misconceptions in the market and the patient's mind because many of them were going back to the full-blown diabetes with complications. So, reversal, जो हमारे simple शब्द है कि diabetes खत्म हो गई है, is the reversal, but without any support. But now this term has been updated by DID2022.
Great. So, but still there is some gray zone. So, Dr. Pantu, clarify if there is a huge difference between remission and reversal, or there is thin line.
Yeah, thank you, sir, and thank you, DID team as well. So basically, as he said, what is reversal? Reversal means you go to normal glycemia without much. Now you don't need any support for that. But the term has been discarded. The reason was very simple. For anything to be described as reversal, you need to have a long follow-up till then. Then only you can say it's reversed or cured. Whatever time it could be ambiguous term. So the term has been changed to remission, and that is what the ADA and other guidelines have accepted. So it's more a remission rather than a reversal. So remission, obviously, you can accomplish. That means there are chances that you can maintain that what is required for remission, and you might be in remission. But unfortunately, most of the trials have been able to establish up to 2 years. So remission can be there up to 2 years. That means he has achieved normal glycemia when it is completed partial, which my panelists is going to say. But then we don't have a data to say whether the remission can be a far-fetched goal or off. So let's see what we get more from this.
Okay, so like the glycemic control, we have something like a normal NGT. Then the IGT or at risk and then diabetes. Right? So on those lines, do you have anything like a partial remission or complete remission?
Thank you, Gary, for inviting us. And Pakistan has already said remission. Partial remission and complete remission can be classified as on the basis of HbA1c to be precise. HbA1c of less than 6.5 and more than 5.7 could be termed as partial remission. And HbA1c of less than 5.7 or 5.5 could be termed as complete remission. But it should be sustained for more than 6 months. That is more importantly, without any pharmacological interventions.
Fine. So before deciding on the therapy, we must actually know about the basic pathophysiology. Very basic. Now, if we go reverse cascade, so what is the pathophysiology, the pathobiology behind the reversal of diabetes or remission of diabetes?
Yeah, so pathophysiology, we were studying since long in our college in the type 2 insulin resistance, insulin secretion, all those things, all the materials and stuff. But for remission, you basically require the liver fat, which is the main constraint cycle hypothesis, in which we see that there is a load on the liver of the fat, it is spilling to the pancreas, and it is causing blunting of insulin response. So once you are decreasing the liver fat by vigorous 15% weight loss, so your load on the liver of the fat will be reduced, and the mexican pancreatic fat load will be reduced, and the patient may go into remission because of the improved insulin sensitivity in the liver part and in the pancreatic part. So insulin secretion is improved, resistance is decreased, and the patient's basal fasting glucose goes down because of the decreased liver fat and improvement. So insulin sensitivity is improved and it leads to the remission. So basically, weight loss is very important criteria, and the twin cycle hypothesis is what it teaches us we have to reverse that.
So basically, insulin secretion and resistance. By weight loss, you are primarily trying to reduce the resistance, and then of course the cascade of the liver fat and so on and so forth. So obviously, every patient would wish to reverse diabetes so that they can live on it. Let's be honest. Now, Dr. Pati, is there any time this won't. So any idea on that?
Yeah, obviously every patient cannot be reversed. That's true, and that's accepted now. So, which are the patients which we can at least go for plan that this patient can get reversed? So, basically, number one, the duration of diabetes. The lower the duration, the better chances of him getting reversed. Number two, the patient is having glycemic status which is better. It's not a very bad glycemic status. That's another criteria which is also important. Number three, obviously the patient needs to be very motivated in order to follow what are the various mechanisms or means to get reversed. So this is also extremely important. Along with that, you have other factors as well which you need to understand that these are a group of patients who can be reversed. Further, there are classes of diabetes which are the one which should be thought about reversing. Like, for example, we have seen in COVID situation acute stress patients, definitely one of them. Number two, obviously, bariatric surgery is another one which we have seen remission or reversal as we call it. Number three, obviously, is wherever you have this drug-induced diabetes, there are chances there as well. And number four is gestational diabetes. After GDM, you must have seen the patient going into remission. So these are the four major classes. But along with that, if the patient is motivated enough to lose acute calorie, loss of acute calories, this is a patient who can be reversed. So this is one such group which can be reversed. And a whole lot of group, particularly whenever you have acute situations, these are not the group where you should even plan out reversing. Okay? Those with a bad glycemic history, these are patients who cannot be reversed. They should be known. Those who are in multiple drugs, including insulin alone, these are the patients who are not, which are likely not to be reversed. So these are the various categories which you should think. And if you don't have the individual should be the one who should dictate. And our healthcare provider need to plan out the therapy accordingly and give option and educate the patient and interact with the patient, right? Who are the one candidate who diabetes reversal or diabetes remission can do.
Wonderful. So, what you have emphasized is that obviously resistance should go down, but also the patient should have a decent functional venous and mass. Maybe shortage of diabetes, maybe good control, or maybe the drugs which are not glucose and not clogging the calories. So both are equally important. The functional venous and mass, and of course the resistance reduction. Now this question, I guess the answer is more or less simple, but I am putting this forward because so many young people come to us. The parents basically ask, "This sir is ठीक." So maybe 7-year-old, 8-year-old child with type 1 diabetes. So is type 1 diabetes reversible?
That's a very typical question. Basically, see, as Dr. Ashish Partisan has already told the basic pathophysiological benefits in type 2 diabetes remission, it is the benefits obtained as increasing sensitivity of insulin because we have functional beta cells. But in type 1 diabetes, we have complete insulin deficiency. There is no role of getting a reversal of diabetes because the patient had to be on the insulin whole of his life. So there is no point in saying okay, we can get diabetes reversed or in any other way we can omit his necessity of insulin. That is the main point. So we need to understand we have certain limitations, we have certain conditions wherein we can say that this could be reversed in type 2 diabetes, but in type 1 diabetes it would not be reversed.
Great, but Abhishek, I want to know about the honeymoon phase because that may be mistaken for reversal.
That could be a bit of a honeymoon phase is there, but we should not actually be very happy in that because कुछ भी दे दे वो तो अगर ओरल प्लेटफॉर्म से भी काम कर देगा because he's in that phase.
Yeah. So the honeymoon phase, 5 to 6 months to maybe 2.5 years. It may last in a type 1 diabetic patient, but it should not be mistaken with liver. That's very important. So this apart, now, Dr. Ashish, what will be the most important steps you feel towards achieving the remission?
See, the studies have shown the weight loss is the most important step because loss of 15% of body weight have shown in the studies that it is decreasing the liver fat and the pancreatic fat, ultimately the positive things are going on in the body. So weight loss is a very important aspect for the remission and for maintaining also. You have to be on the weight loss maintenance. That is part is responded to the difficult part. And then our patients are also facing in India. It is actually not possible because Dashera hai, Diwali hai, kuch Aati hai, Aati hai, सब कुछ त्योहार ही त्योहार है, हर हफ्ते. So maintenance of weight loss after achieving it is a big problem. But the question is, which is the most important, is the weight loss.
And weight loss, no matter how you achieve it, yeah, physiologically. Okay. So what are the modalities? Let's say weight loss is the key. So I guess, Dr. Patti, what are the modalities by which you reach towards this goal? That is the way.
Yes. Thank you. Most of the studies have mainly shown which are the dietary way you need to lose weight. There are only two criteria, two types of diet which have been prescribed for remission. One is the low carbohydrate diet. And low carbohydrate diet means it should be less than 50 grams per day. It's very difficult for Indian population, most of us population. Or you can go for low calorie diet. Now, low calorie diet or very low calorie diet can lead to remission because that can lead to acute calorie loss. So, in both these kind of diets, you can achieve it. Along with that, if you have been able to achieve that weight loss, say what is said 15 kgs of weight loss, probably you go into remission. But then, if you gain even a little bit of weight again, then you may not be able to sustain that remission. So, in order to sustain that, exercise also plays a very important part of managing the weight loss which you have achieved through dietary methods. And obviously, the last part, obviously, we all know about the surgery part, the bariatric surgery has led to weight loss, acute weight loss. Though I think one of you are going to talk on that. So basically, that is another criteria, another way, a modality where you can go for weight loss and you might achieve diabetes.
Great. You have to follow a formula EDM, exercise, diet, and meditation. So through maintaining this, you can achieve remission and suspend remission. You have to follow this.
Abhishek, we talked about diet and something called keto diet is in vogue amongst the 3 pages of the page 3 personality diet. So, what is a low calorie diet, a very low calorie, and a keto diet? And what possible elements, as a day, I would like to know what possible elements. So, what would you advise a patient on keto diet? Right? So,
Sir, basically, what everyone, I think, understands should also agree that keto diet has not been advocated as a tool for diabetes remission. Only 2 diets which have been advised in the protocols are low calorie diets, very low calorie diets, low carbohydrates. These are the 2 big categories where you can say we can achieve remission of diabetes. Although there is a certain percentage of weight loss even with the keto diets. But the problem with keto diet is ketosis. That is the most important thing. Because most of the patients are type 2 diabetic patients are prone for developing ketoacidosis. So that is the point where we need to identify or clarify as keto diets are not the diets where we can take a sustainable diabetic base. So it is we should take. Participants has told low carbohydrate, And low protein diet is also seen as very low protein diet could be of 20 grams per day. This is advised, although very low and moderate, but very low protein diet and low protein diet are actually seen as a beneficial for
Ashish, on those lines, role of exercise and pediatric surgery, and obviously all doesn't seem well, so side effects also of these modalities. Every modality has side effect, maybe a drug, diet, exercise, and surgery. If there's an effect, there has to be side effect. So, on the exercise and pediatric part, please tell us the benefits and the possible pitfalls if not beneficial.
The bariatric surgery has given a very wonderful results as we have seen in the obese and very moderate obesity patients. They have seen remission or reversal of diabetes immediately within 2 days, 2 weeks after the surgery before the weight loss due to the hormonal changes. Because the blood-brain axis which was dysregulated became regulated and the patient has low intake of food and ultimately the calories are going less. Ultimately we are getting a low calorie diet. Basically stomach at the bypass. So bariatric surgery helps a lot in normalizing the blood glucose levels through the hormonal disbalance improves and the patient goes into the remission. And sustainability is a big problem in bariatric surgery also. If the patients again start eating bad things and even they gain the weight, again the sugar will go high. So weight loss happens, but before that the glucose levels balances and comes down to normal with the bariatric surgery. And the pitfalls are there for every treatment, as I asked, that there will be micronutrient deficiency, patient will have nausea, vomiting, and extreme weakness. As we have seen the patients coming to our clinic that we have done pediatric surgery, now we are not able to do it, we are having nausea, vomiting, and very weakness due to micronutrient deficiency. So long-term maintenance of that is also a big problem. And exercise definitely, the patient of diabetes, they want remission, but with the chances of ketosis or any other problem, we have to check it. Exercise programs also. So all the treatments have positive things and negative things. But bariatric surgery, you have to be cautious with the selection of patient is important because for the sake of doing the surgery, they are doing the non-government categories also. So you have to be vigilant whom you have to advise bariatric surgery.
Yes, so pediatric surgery first is motivation. And I'll tell you an instance 3 days back. I had a patient, sugars all over the place, excuses everything, speeds every day. And once the surgery was done, sugars came back to normal levels without insulin. When I say normal, I do not mean the IHU they were there. But without insulin, sugars were not in the diabetic range. Now the issue is that after surgery, they advise liquid diet. And they advise juice too. And the day he had juice, fasting sugar for 140. And I had been telling him for 10 years, no juices for you, and just one paper which said a glass of juice, and he had this. Because of the excuse, he wanted to make that caise feel. So the patient has to be motivated, pre-surgery, post-surgery, all. As regards exercise, it's wonderful, but we must be aware of the ticking clock hypothesis about macrovascular complications that starts much before diabetes onset. So it's always worthwhile that if some person is trying to do an exhaustive exercise, a cardiac evaluation should be done. Nothing lost there apart from a few bucks. That should be done. So we've seen people collapsing on treadmill. So that possibly could be a side effect of exercise. I'm not saying that. But majority, usually it does not happen, but one life lost in the life. So before embarking upon a heavy exercise, I guess cardiac evaluation should be done. Dr. Patni, the last comments about the modalities, right? The diet exercise. Before we go on to the next question, would you like to sum up about the modalities, the exercise, diet, and
So basically, if you are planning out diabetes remission, we don't call it reversal anymore. So what we need to understand that it has to be acute calorie loss to the tune of almost 15 kgs if you really want to have remission. But yes, different studies have shown even a 10% reduction is good enough, or rather in certain population that you have the BMI roughly around 35-36, a 10% to 15% correction would be good enough to get remission. So that means we are not always dependent on the BMI to plan out that this individual is going to have remission or this individual is going to have benefits. So it's not the BMI, because at what happens in the study which we has been undergone, particularly the direct study, where they have shown even with 45 BMI, that not coming down, the BMI not coming down, but there is active weight loss or active calorie loss, you are able to go into remission to the tune of what the study showed. I'm just thinking of this study actually, which probably you are going to ask me later. The reason is simple, because even in that particular, which was in the primary care setting in Scottish area, where actually only 46% in the population selected. First and foremost, only 25% of the population was selected, participated, and even that only 46% to get remission. And that remission also at the 1 year did not suffice. From 46 it went down to 23%. So basically, what is so important is the BMI need not be the criteria only which can give you an idea that this person is going to get into remission. So that's a little away from what the topic was and what Sir asked. What I mean the modalities mean, number one, obviously diet. We have already spoken about the two different diets which have been advocated. That has to be sustained by exercise, and this you need a lot of counseling and education for the patient to understand what they want and what they need to achieve and how do they need to sustain if you really want that remission to continue for long. And the third part, obviously, as is already explained, it is the interplay of the GI hormones which changes because of bariatric surgery, where you have a better glycemic control prior to weight loss. So you can well imagine that it's not like that everything is very clear cut. So all these three factors will come into play and we might achieve remission. So we have to be very, further studies need to be done more, and that is why this direct study was, because it was a real world study in the primary care setting. So more studies are required in order to establish that this remission can be continued for long.
Okay, so I'm so glad you got to that study. In fact, no talk or discussion on remission is complete without the direct trial. Dr. Patni, on the same note, if you could continue, that whether the stringence of direct trial is possible in routine practice. So they were driving on the Yamuna Expressway. Can be done in Chandni Chowk on the same lines. Yeah, and what are the pitfalls? Yeah.
First and foremost, Scotland is not India. Number one. The study was done in Scotland primary care setting, so we cannot expect that same mohalla clinic we can do it. I don't think so. So practically, what I mean to say is that this is other indicators. We can design on this line, and maybe we can formulate our own plans in order to come to some kind of conclusion. But definitely, one thing is for sure, we have seen in our clinical practice as well, that the patient can achieve remission for a certain period in type 2 diabetes. You must have seen lots of patients who have been aggressively treated initially, they are off pharmacotherapy and they are able to maintain it, they are very disciplined in their life, a lot of motivation goes into that. So if they can maintain it, they can really maintain the remission for a long time. But then, once you go away from off mark, probably you come back to square one. So that is what has happened actually.
And this obviously was an institutional study, so we can't expect it happening at home. As Ashish said, कभी शादी है, कभी दावत है, कभी ब्याह है, शुरू होता नहीं और हर महीने होंगे. So I guess stringence and dedication is the key to achieving the target. So as Dr. Bhatti said that once you misbehave, you go back to square one. Right? So Abhishek, can you tell us, is there something a re-remission or reversal?
Certainly, there's basically what is reversal of diabetes is a cluster of activities which we direct the patient. Diet control, weight loss, exercise, regular. So why can't we get a re-reversal of diabetes basically? Because सबको patient को दोबारा करवा सकते. We can again see basically हमारे what we Indians are very non-compliant towards the proper follow-up of with a doctor, the proper follow-up of the medications. So that is more important because primary failure is a reality in Indian scenarios. That is what I said. कि हमको Scotland is not India, तो हमको एक वैसा direction देना पड़ेगा. So that is the reason why re-reversal could possibly be a very good scenario in Indian population. Yeah.
I think that you got it a little wrong. Re-reversal is we wanted a diabetic reversal. We उसको वापस re-reverse करना है. And that means the patient goes back into diabetic state. यहाँ पे क्या होता है? This is very clear and clinical we see every day. What happens? We have been able to achieve that remission. Patient is very happy. He does the follow-up for next 3-6 months, and thereafter we lose him for follow-ups. He has been maintaining his lifestyle for the first 6, 7, 8 months time, and then you can see, and he does report maybe digitally or physically that my blood sugars are very low. So this particular notion that everything is okay with me, that grabs him into the and then he uses the follow-ups. He doesn't see his blood sugars, etc., etc. It's a very common stuff that he ends up after 3 years in the same clinic with HbA1c because much higher, which is much higher now than what he presented. This is actually the concept.
That is what I said. Not because of non-compliance, diabetes reversal, but we can get a reversal along with exercise, diet, and proper.
So this is very
Proper. Yeah, that's what.
as we can reverse the idea of revision. So it's very common stuff that we go back to square one, back to rather worse than what it was. That is more problematic. So we have to be very careful.
What I have understood in the literature that I have, patient wants to go to remission because of just 2 reasons. Number 1, can insulin be stopped? And number 2, can he eat whatever he wants to eat? However, as clinicians, we must understand that it is a temporary phenomenon at best 2 years, maybe 2.5. Data is still 2 years only. Now, what I want to know from you, Dr. Denga, is that can a patient who has achieved remission develop diabetic complications?
So, the patient who has achieved remission, he will be very happy. But the studies have shown that still 10% can develop cardiovascular complications of the level of diabetes. So, he is vigilant. He has to be in follow-up with the doctor as part of the treatment. So don't drag everything with the remission. He won't drag on the diet, exercise, and follow-up with your doctor and screening of the complications yearly. Because they can develop the microvascular complications. That is the thing we have to keep in mind.
And obviously, macrovascular can happen because of the leaking clot. Okay, so before I allow questions from the audience, one last word from each of you. So we started about a couple of One last word.
So the concept of diabetic remission is on both now. And we should try to plan out our own way of getting certain patients who can fit into this pocket, in this particular group for remission. And then the remission need to be sustained. That should be the more, that should be the idea behind even planning out a remission. But one thing is for sure, if if suppose a patient goes into remission and stays in remission for certain time, so and during that time particularly, he if he does proper follow-ups with the healthcare providers and keep all his biochemistry in check, then probably the complications are at bay as well. That is also important. So this is why I thought the remission should be tried in certain group of population, but with proper education and counseling, so that the patient take it into confidence and a proper interaction happens with the patient.
That is quite so important because हम क्या करते हैं, we don't actually as a clinician take time with the patient because हमारा इतना workload होता है. So remission period what I feel is proper indulgence of a doctor is also very much important. उसको patient को time देना पड़ेगा, उसको proper follow up देना पड़ेगा आपके clinic को. That in that way we can keep the remission properly and full.
Basically, you have to make a team. You can't do it as a doctor. You can only make a team of your paramedical staff, tell them to follow these patients, call them FTP, or family support. Family counseling is very important because without family support, they can't be a radical condition. Because if the family is supporting him in the diet and exercise, then only he can sustain the remission. Because sustainability is a big problem. So you can make a team of paramedical staff dietitian and you can keep the patient healthy, keep the follow-up of that patient and then only you can achieve long-term results.
Okay, thank you so much, panelists and everybody for the audience. And please address the panelists you want to ask.
I think I can be audible like that also without.
Yes, a nice vocal cords. Yes, go ahead.
So, I would like to just make a comment and then I would like to have your opinion also. My personal feeling is that a lot of discussion and talk, even that we are talking right now about diabetes reversal, has come into play because after we got the results of the direct. And the other big, I would say, problem in our country is the commercial social media. There are many companies who are riding on this wave and who are taking our patients for granted because they will obviously want to get treated of diabetes. Everything that we just talked about diabetes, that is the basic diabetes treatment that we all have been doing, I think, since past 2 decades. My practice, these are the basic tenets of any diabetes practice. But one thing which I have myself tried, and it's not my they are obviously trials. There is a big trial by Dr. Mohan also. That is about when the patient is just diagnosed diabetes, giving insulin therapy, intensive insulin therapy. In that, there is sufficient evidence that diabetes is sent into remission for at least 2 to 3 years. That is what we've seen in our clinical practice also. But unfortunately, because of these trials that we have tried, our intervention with diabetics, they are no way, they are not bad, they are actually very good. This is what we want all our patients to do. But unfortunately, it has only been done for some time with name diets which have their own complications, like you just talked about keto diets. But one thing, starting insulin at the very onset of diagnosis of diabetes, which actually does send patients into remission for up to 2 to 3 years, and that is irrespective of the rate also. So what is your opinion about this?
I know about this Dr. Mohan's basically study, and he did say if you give a 4 weeks of insulin, you have to off any medication for 3 years. So basically, it's a very controversial stuff. Dr. Mohan's study to point out, but it's not been accepted by any association worldwide.
It's not Dr. Mohan's study. This is not just Dr. Mohan's study. Dr. Mohan's study is initiating Brazil.
Insulin therapy aggressively during the first few weeks, and then the patient was off any oral weeks or months, and he was sustained for 2 years in the obese and the high A1C patients because the glucotoxicity was reduced, the pancreatic glucotoxicity glanding response was taken off, and the beta cell function was improved.
Thing is that, sir, Kapoor sir would also agree that what is reversal is why we are representing weight loss mainly as the best tool for reversal is because even what is percentage of decrease, fat decrease even in pancreas and liver would actually improve the insulin system drastically. This is the way how we can achieve remission. Giving insulin at treatment patient would not cover all these issues. Basically, that's the point.
So maybe leukotoxicity. Any prescription for diabetes is incomplete without the mention of diet and exercise. And these would form the control group. As far as reversion is concerned, we have to go a step further. So more vigorous exercise, lesser calories. So that is a step further as compared to the routine advice that we give.
Hello. Hello. Sir, this is to inform that diabetes reversal or diabetes remission is always in pen and paper, never in practice. Hello. It's okay. Am I audible? Hello. Okay. Diabetes remission or diabetes reversal is always in pen and paper, never in practice. That is clinical. That is seen in clinical practice. It is always on pen and paper, never in clinical practice.
Yeah, we have discussed that, but nonetheless, as academicians, we should be aware that such entity exists, and we should always motivate our patients to behave better on exercise. Now, it is much simpler said than done, but this entity exists so.
Once the patient is in remission, maybe after 2 years or 1 year or 6 months, has any study been done during remission? What has been the incidence of form effect? Any study? Thus, there is a study which has shown that there are chances of increase in the complications, many microvascular complications. The studies they have seen. Percentage-wise, we have not seen the figure, but you have to be vigilant that there will be complications. There can have been complications. So you don't be happy with the application of the complications.
What is surprising legacy to
Legacy. You said that once diabetes is there, in the case of remission also, the complications are falling through. Maybe at a very slowly.
So even in the IGT phase, if we can improve the insulin sensitivity, cardiovascular or major macrovascular complication would come. The relative risk reduction is almost same as with totally diabetic patients. So even in pre-diabetes and diabetes, the risk reversal is almost same. Even with
we have seen the acute correction of glycemia, they do the retinopathy problems to increase, neuropathic increase. Acute decrease in the sugar levels cause some chances of increase.
Thank you so much. I've been asked to wind up. It was a pleasure, sir. Thank you so much.
So, in addition to the Sabka Saath, Sabka Vikas Nahi, family support is very important. Then we will get
Thank you everyone for a wonderful session. I now request Dr. Dheeraj Kapoor to please present token of appreciation to our panelists. in pregnancy. I now invite our moderator for this session, Dr. Prahlad Chavla, Director and Head, Nishkam Diabetes Care Center and Research, Ghaziabad.
नमस्कार। सबसे पहले मैं धन्यवाद देना चाहूँगा ऑर्गेनाइजिंग टीम को। ये बहुत ही अच्छा कॉन्सेप्ट है डेवलप फ्री डायबिटीज, और उसी के तहत हम लोग ये कर रहे हैं। लंच टाइम में थोड़ा सा ऑडियंस कम रहेगी, मैंने तो बिल्कुल साथ। आज हम we discussed about the diabetes in pregnancy. To discuss and the queries, we have galaxy of panelists with us. They call upon. Saurabh, so should we read date for some time? So we should start. That, we are starting panel discussion on diabetes and pregnancy, and for that we have Galaxy experts with us. To begin with, we have Shalini Gatti, who is consultant diabetologist and director Life Care Diabetes Center, New Delhi. Digital executive council member RSSBI. She is part of various RSSBI guidelines also. And we also have Dr. Jugal Kishore Sharma sir, and he is presently medical director and Central Delhi Diabetes Center, New Delhi, and visiting professor and faculty at JN Medical College. He is now presently vice president vice of ACP, American College of Physicians, and vice president Genetic Society. We also have Professor Meenakshi Dhar. She is additional professor in Health Department of Medicine, All India Institute of Medical Science, Rishikesh. She has previously worked as associate assistant professor in Himalayan Hospital. And along with it, we have Dr. Ajay Tiwari, and he is presently secretary with the RSSBI chapter and son of Diabetes India. Many things in this country. So keep the ball rolling, and we have the slides, please. Okay, we'll start this, and I will start with the quote. My sugars are high, and I must worry, since within my womb, a child I carry must reduce the sugar before it is too late, or maybe they'll end up with high blood pressure. We have the galaxy of speakers with us. My left, I start with Professor Meenakshi Dhar. This is the question for you. Really? Not able to see this question here. Questions are not visible on the screen. What are the diagnostic criteria for India? How to differentiate pre-existing undiagnosed diabetes from diabetes?
Good afternoon, everybody. The gestational diabetes, when we talk about gestational diabetes, it usually means that there is a raised blood sugars or raised blood sugars in a pregnant female. Initially, we used to say that when in any part of the pregnancy, when the raised sugars are there, after the within the 28 weeks, when the blood sugars are above the target levels, then we say that it is a gestational diabetes. And what the ADA has set the targets for blood sugar is fasting if it is more than 90 to 95, and after 1 hour of 75 grams of glucose, it's more than 180, and after 2 hours, it's more than 155. So if at any time the two readings are one or more than one reading is above the target levels, then we diagnose the patient having a gestational diabetes. When it is diagnosed after 24 weeks. The second part is that there are many cases when we see that the blood sugars are raised in the first trimester. So how to say that whether it is a part of gestational diabetes or it is pre-diabetes, the diabetes not existing before the pregnancy. So if at any point of time in the first trimester, especially if the HbA1c levels are above 6.5, so that gives indication that it was what we say is an over diabetes. So if the patient had diabetes, but it was maybe undiagnosed, and the pregnancy, and after she has conceived the baby, that undiagnosed diabetes has become an over diabetes. So that is how you can differentiate between the diabetes which is previously distinct from the gene.
So thing is that if it is found, initial part of the pregnancy, it is most likely the over diabetes, and if it is during the screening 24 to 28 weeks, then it is most likely female. So, next question to Dr. Shalini. What are the adverse perinatal outcome and subsequent effects of hyperglycemia in pregnancy?
So before I go to that, let me just talk that in India now, the government of India has recommended the DIPSI guidelines to be used as diagnostic criteria even for GDM. Because the problem in pregnancy is if you call the female fasting on another day, make her sit for 2 hours, give her glucose, do a 1 hour, do a 2 hour, not only does it need more resources, infrastructure, lot of at the first point in contact when she comes to you, give her 75-gram glucose and check her blood glucose in 2 hours. This can be done with a standardized glucometer. So even in a village, in a rural setting where you really do not have a plasma collection kind of a facility available, if you have a standardized glucometer, you can do a 2 hour value. If that is more than 140, that is to be treated as gestational diabetes. When to test? Again, DIPSI says because a large number of females are pre-diabetic, sometimes even diabetic, and they are not aware. So the first time that she comes to the AMC OPD for registration, that is the time when you need to do the first test. If that is negative, do it again in the second trimester and then again in the third trimester. For very high risk patients, they recommend 34 weeks also, between 34 to 36 weeks also if you are seeing macrosomia, if there's polyhydramnios. Sugars have been normal, but you've seen polyhydramnios. Even at 34 to 36 weeks, you can again do a 75-gram glucose test to diagnose GDM even at that point in time. So I think DIPSI criteria has been advocated as a standard criteria for our country looking at the challenges that we face in diagnosing diabetes. Why we talking is because of the adverse maternal and perinatal outcomes, my question actually. So when it comes to obviously, if it is pre-gestational diabetes, which means pre-existing diabetes, coming were
Fetus inside the womb should not know his mother or having the hyperglycemia. If he is not sensing hyperglycemia, you have to make such a control. Only then you can prevent the complications of this conditions. So, Dr. Ajay, GDM in forms of pre-diabetes. What is your take? Can you say?
So, first of all, I would like to add on to the DIPSI guideline because they are very pertinent to our settings. So, the cutoff is 140, 75 gram to 75. The test is done 2 hours after that. So, that is very important. And there is also a category that is called DID2022. That is is gestational glucose tolerance, if it is more than 120. These patients are also to be followed properly. So that is about that. And as regards to gestational diabetes mellitus. So gestational diabetes, basically we have to understand that pregnancy is a diabetogenic state. So every female, for facilitation of the for the fetus, there is a state of diabetogenic state. Postpartum sugars are likely to rise. So that is with all the pregnancies. That is for the facilitation of the fetus. And the mother's resources are closer to the child. And in usual case, increased insulin secretion that compensates for that postprandial sugar rise that can increase. So, but if the insulin reserves of the mother are less, so then that will not be able to compensate for the sugars that are rising because of the effect of the placental hormones. So we have to understand if the mother has got a optimum insulin secretion, then this diabetogenic potential will be negated. But if it is compromised, then we will have gestational. So that is why we are so much concerned about the future risk of impaired glucose tolerance and future diabetes, because these women are the right candidate to be followed and to be educated, and they have to have a future risk of diabetes.
So it is like a pre-diabetes. It means it is like a stress. When in a normal pre-diabetic patient, whenever patient has a stress, like either giving corticosteroids or anything, patient never diabetes. So same is the case with this fitness. So we can say it is a state of pre-diabetes.
I would like to add to it that in the late first trimester and the early second trimester, there is significant insulin resistance also. So in these people, then that adds to the other problems. So that also we have to look for, and this is also because of the hormonal changes.
So, what are the risk factors for the GDM?
The risk factors for the GDM are if the body mass index of the female is more than 25, number one. If there is any history of in the family history of gestational diabetes, or in the siblings or in the mother, then if there are other comorbid conditions, obesity, that high BMI, body mass index, I have already told you about that. Then the other associated conditions, like if there is hypertension, then if there is dyslipidemia, and then if there is a history of smoking, or if the lady is already smoking, then these are the various risk factors for the GDM.
High age is also.
Yes.
Increasing age is
Yes.
also an important aspect.
Other hypertensive states like polycystic disease, and if advanced stage more than 40 is there. And if there is a previous one of the last birth, the baby was more than 4 kgs, that is the result expected. And as I said, in the past, if she has a GDM in the past pregnancy, definitely she is having a 40% chance of having it this time also.
So as far as the screening is concerned, I don't think risk factors are important. Universal screening is important nowadays. Every pregnant lady has to be screened in that. Charlie has already explained. Every stage we have to screen it. Either in early pregnancy and during the second trimester, and even sometimes we are seeing, because as a pregnancy age is increasing, we are seeing patients with this GDM diagnosed at the time of third trimester. So we have to be very careful. So, Meenakshi, current recommendations by ABU for the management of GDM.
See, ABA recommends that as for the management of GDM, the nutrition and exercise that forms the basis of treatment for any diabetes, and same is for the for gestational diabetes as well. And when you talk about the nutrition therapy, they recommend that the diet has to fit in the divided diet is to be given in a divided order, like there has to be three major meals and 3 to 4 snacks should be in between. And regarding the distribution of the liver diet should at least have 40% of the carbohydrates, 20% of proteins, and rest 40% should be the fats. And taking fruits, excess of fruits, taking fruits in a good quantity, and that is also recommended. And apart from that, the exercise. They recommend that at least the moderate exercise should be done by all the pregnant females, unless there is some static dedication to that exercise. That should be done. And if we continue with this basically insulin therapy plus the exercise, if they fail, and fail means that if the targets are not attained after at least 1/4 and 1 or 2 weeks of glucose monitoring, then we can shift to the pharmacotherapy for the patient. And the drugs which are used for the management of the GDM, the best is the insulin. I also agree that best is the insulin, but in case that insulin, especially in our settings, most of the pregnant females won't be able to take insulin because they are not that much educated. It's very difficult to handle insulin at home. So metformin is the alternative as a pharmacotherapy for the treatment of GDM.
Although I'll go with nowadays glyceride because it is also being found no adverse effects.
Just adding on to what Bang said, ADA this time has very clearly come out and said that insulin is to be preferred and is the standard for any hyperglycemia in pregnancy, immaterial of whether it is pre-GDM or GDM. Metformin is to be used only in certain conditions, like Bang said, in a resource-deprived setting or where you are 100% sure that the patient cannot accept insulin. The problem with metformin is the current literature that we are seeing with metformin, because earlier the safety of metformin was on the basis of MIG study. MIG data clearly showed that women were given metformin and there was no major problem, so they said okay, metformin can be given. But now we have a lot of studies, MIG tofu, follow-up of the MIG study, followed by the MITI study, Mompod study. Most of these studies have clearly shown that the children who were exposed to metformin intrauterine at 18 months of age, they already had a higher skin fold thickness. By the time they turned 2 years, they had a higher waist circumference. By the time they turned 9 years, and now we have 11-year follow-up, which has shown that these children have higher BMIs, are more obese, and are at a higher risk of developing NCDs. Now, whether that priming is happening because of metformin is still under exploration. So, seeing all that data, plus metformin has always been associated with a slightly increased risk of prematurity. Again, in India, where we have a lot of underlying beta cell insulin deficiency also as an impaired factor, resistance is less, but most of these females eventually do need insulin. So that is why now the guidelines are clear, including the DIPSI guidelines. Only if it is a resource, right, a place where you cannot give metformin, where you cannot give insulin, or if it is very mild gestational diabetes, a mild degree of dysglycemia somewhere towards the last trimester, that is when you can give metformin. Otherwise, insulin has to be given, and that is the drug of choice. Even most of the guidelines now say, even for PCOS women who had conceived when they were on metformin, if at all the OBG does not want to stop metformin due to fear of early pregnancy loss, it can be continued only till 12 weeks. It has to be stopped at that point in time. And again, if you see an element of insulin resistance coming in addition to insulin, where she needs high doses of insulin, then maybe after 22 weeks, you can again add on metformin. Glyburide has been completely written off. Only the NICE UK guidelines still talk of glyburide, but the American guidelines and the Indian guidelines have clearly said glyburide, or for that matter, none of the sulfonylureas to be used in pregnancy because of neonatal hypoglycemia, which is seen in patients who were given sulfonylurea. So amongst the OADs, as of today, the stand is metformin only in certain conditions. Otherwise, it has to be insulin all the way.
So, in clinical practice, what is happening sometimes? I recently had 2 patients. They said कि कुछ भी हो जाए, हम नहीं लेंगे insurance. और they were before pregnancy they were died. In such a situation, what can be done?
So ADA, if you see
see that statement of this is statement what they have said that if there are cultural problems and there are other problems like you are not able to communicate with the patient, if the patient is not able to insulin therapy, in those conditions you can consider the oral drugs. So that they have written already there. If there are cultural issues and the educational problem, the patient is not able to therapy. In those conditions, definitely you have to control the glycemia. So they have written this thing, but that is a category E recommendation. And insulin today is the category A recommendation for diabetes management in pregnancy.
There is no doubt that insulin has no contraindication as such.
In case you have such kind of a patient who is adamant on continuing with orals in pregnancy or even metformin, I think the best way would be to take a written informed consent, telling her in detail about the risk of congenital malformations, about the adverse pregnancy outcomes that can happen if the glucose levels are not controlled, and then only I think you should continue with an oral drug.
It's true. But the thing is that guidelines are different and the practical aspects while we take care of our patients is many times different situations. So we have talked about the insulin therapy in pregnancy. So
Insulin therapy in pregnancy, the best approach is the basal bolus therapy. That is the standard and that is the regime which will not lead to hypoglycemia and which will control the hyperglycemia also. Though it is a tedious job, we have to make the patient understand and make him follow the instructions. And in that case, there will be a total involvement of the physician, total involvement of the lady and the family also. So the best is that 50% of the dose required is to be given as the basal dose, and rest is divided into 3 parts: before breakfast, before lunch and before dinner, with a 4 times checking of the blood sugar levels. If this is not feasible, then the second comes, that is the pre-mix insulin. So we can give pre-mix insulins also, and then we can give the human insulin, we can give even these designer insulins also. There is no contraindication for that. So this is the best thing.
So what the practical situation is, many times fasting blood sugar is very high. And post-prandials with the diet controls are good.
In that case, we have to start with the basal insulin. Give basal insulin, so that will cover the fasting. And rest, as you said, they are already covered with the diet. So the role of the medical, nutrition is also there. So that has to be taken care of alongside the insulin.
What the target should be? What are the targets?
Targets are fasting between 80 to 90. If we check 1 hour post-meal, then that should be less than 140, and 2 hours should be less than 120. These are the targets.
Just adding on to the insulins in pregnancy, all the analogs except for Day222, they are still not cleared for pregnancy. Glargine did have some problems earlier, but now the guidelines say if your patient is pre-gestational diabetic, already on Glargine and is maintaining good glycemic control, then you should not change Glargine. Other and Revlimid are the only 2 intermediate and basal that are considered safe in pregnancy. Amongst the bolus insulins, or glulazine still does not have data in pregnancy. Aspart or Lispro, both of them are safe in pregnancy. Rather, the fast-acting Aspart we are using a lot now because of the immediate action, and you see a very good control of the postprandial. The 2-hour value comes down very fast with PIAS. If your patient can afford the analogs, you can use these. Otherwise, simple rapid-acting human insulin, rapid or human insulin, or the NPH are safe in pregnancy. Only Day222 still now as an ultra-long basal is not yet cleared in pregnancy, so I think you should refrain from using that. Glargine you can use, but NPH, Revlimid are the 2 basals that are considered safe and for pregnancy use.
Dr. Adit, what about the use of SMBG versus CGM?
There is the important role of SMBG, because it is not that one time we check the blood sugar levels and that comes to 140 or 120. we should have a 24 hours blood sugar control. So there is a great role of SMBG, and we should train all our patients, all our such kind of patients to go for the SMBG, because two very important roles in for SMBG are, one is in pregnancy and second is in the type 1 diabetic patients. So SMBG is very important. We should definitely advocate. We should make our patients understand and train the patient to do it and show the importance. Yes, CGM, wherever possible CGM, but role of CGM is more in type 1 diabetic patients as compared to this, because in these DDM patients we can even take care by the SMBG.
How frequent you do SMBG?
4-point testing is important. 4-point after every meals and the fasting. So that is what we are doing in gestational diabetes and hyperglycemia. I should say, call it as hyperglycemia. And as regards to CGM, so now AD has also recommended the 5-based criteria for pregnancy, hyperglycemia in pregnancy. That is 63 to 140, 70% of the times. So that is also to be understood that yes, now they have already understood this thing, but still SLBG is preferred over this glucose monitoring as a method of.
Shali, do you agree all the pre-meals or fasting and post-meal 1 hour?
Ideally, in pregnancy, if your patient is motivated enough, a 7-point SMPG, at least a 6-point, which means pre-meal and 2 hours post-meal should be done. But then obviously, most of the times it is not acceptable to a patient. So that is where at least a 4-point SMPG, which involves a fasting, followed by a 2 hours post-prandial, post-lunch and a post-dinner should definitely be done. Of course, if you are seeing polyhydramnios or macrosomia still developing, this is where you need to go for more aggressive SMPG, and this is where the role of CGM also comes in to look at the fluctuations. And that is why the ADA has also clearly said that CGM in type 1 diabetes, the postprandial spikes are basically associated with macrosomia. So that is why if through CGM or through SMPG you are able to catch hold of the postprandial spikes and get them down, you will have better outcomes. So ideally, pre-meal and 2 hours post-meal for all the 3 meals should be done. But if that is not, like Dr. J.K. Sharma very clearly said, 4-point SMPG should definitely be done, which means 1 fasting, followed by 2 hours post-breakfast, post-lunch and post-dinner. 2 hours. Earlier there was some literature which said that the 1 hour value more than 140 is associated with macrosomia, but then it was seen that the insulin reserves of the different populations were different. Like we say, the Caucasians are different from the Indians. Southeast Asians have an 11-fold increased risk of gestational diabetes compared to the Caucasians, and that is why they see universal screening is important. So similarly, there are studies which have shown that ideally a 2-hour postprandial is the exact indicator showing a lot of connection with macrosomia. So now the American guidelines as well as the Indian guidelines have clearly said 2 hours. There is some studies which are still coming in on the 1 hour, but as of now, most of the guidelines are silent on using 1 hour. ADA does put that there, 1 hour less than 140 or a 2 hour less than 120, but otherwise most of the guidelines are still advocating a 2 hour value compared to a 1 hour.
So SMPG, 4 points, 1 fasting and 2 hours after breakfast, 2 hours after lunch and 2 hours after dinner. That's
absolutely.
So moving on to next. What is the importance of long-term follow-up in dating with the medium and its pitfall? The importance of long-term follow-up in the lady with the GDM and its pitfall.
Actually, this GDM, as already said in the previous question, that it is a pre-diabetic stage. It has been seen that patients, females who develop GDM, they need to be followed up regularly, and usually after delivery the sugars come down. But repeat testing is to be done at least after 12 to 14 weeks, and it has to be seen that whether they develop diabetes or not. And the literature says that the studies have shown that around 13 to 14 years later, these patients may develop diabetes, and there is a chance that around 40% of them develop diabetes. It all depends on whether after the
So, again, Dr. J.K. Sharma sir, role of preconception counseling and what will be your advice for a lady with an early pregnancy with HbA1c of 8.8?
Early pregnancy with HbA1c of 8.8, it means definitely either it is already existing diabetes unknown to the patient, or because early pregnancy, you want to say that the first month of the first trimester or first month, and if it is 8.8, it means they were already existing diabetes. So there should be a very strict control of diabetes. Otherwise, as Dr. Shalini said, in the first or second trimester, there are a lot of complications and the malformations. So with good glycemic control, the counseling is very important in these patients. And then the fetal examination, or by whatever modality we can find out that yes, there is no, at the time of organogenesis, there is no malformation taken care of, is taken. So that is important. We must control the blood sugar levels. Otherwise, the chances of retinopathy are there.
The problem is this patient HbA1c is great and this patient was on the first visit or the first month of the pregnancy we should have done. What is your say? What do you think you have to advise the patients for medical termination of pregnancy or you can still continue that pregnancy?
I think if there is no complication within time and if we can control the diabetes in at least 2 weeks time, then we should continue with that. What are the time?
Ideally, preconception counseling is very, very important if a lady already has diabetes. So, an HbA1c target of 6.5. Now, there is talk of getting it down to even 6%. So, at least a 6.5% target before she conceives is very important if she is already a known diabetic. In case she was not aware of her diabetic status, she's come to you for the first time in early pregnancy with an HbA1c of 8.8. Now, you have to tell her about the risk of uncontrolled diabetes at this time, the risk of congenital malformations. Offer her a choice of NTP that is available, but you cannot push a patient for NTP. You can continue pregnancy, but you have to start insulin immediately. And it has to be an immediate intensive insulin regime, which means a basal bolus regime, because she's way beyond your target HbA1c. So the decision to continue this pregnancy based on the risks that are involved has to be informed to the patient. Take a written consent that she is aware and she wants to continue the pregnancy. Then you screen her for complications as well, fetal malformations, which is a very high risk in this HbA1c. Put her on intensive insulin regime and try to get the glucose levels down on target as early as possible. So a basal bolus regime is the only choice if she wants to continue pregnancy.
After that, if there is any evidence of congenital malformation, then it should be done.
So we have to look for that. Proper monitoring is important. Timely echo on 18 to 20 weeks, echocardiography is important as well. Only then we can decide. Otherwise, is there any level of HbA1c then we can say?
Recommendation say beyond 9%, 9.5 is the time when you should actually strongly recommend a medical termination. But this is again an area where the obstetricians do not agree. If you talk about a termination, so this is where it has to be a combined decision between you, the obstetrician, as well as the patient. Beyond 9%, ideally the risk of very, very high. So, anything beyond 6.5, the risk increases linearly. 10% for every 1% HbA1c, the risk of congenital malformations. It's 26% beyond 7%, and then every 1% the risk increases 10%. So you need to take a very calculated decision if you want to continue pregnancy here, and that too, I think, intensive insulin regime to bring it down, and very, very thorough scans and regular follow-up to actually pick up any complication happening there and then if required.
And 2 words. One is continuous counseling that should start at the time of puberty. Every girl child at the time of puberty, her parents have been sensitized that in the future marriage or pregnancy, this baby is going to have this problem. So they should be primed about this thing. Secondly, the counseling counseling of the spouse is very important. After marriage, the counseling of the spouse is very important. And no unplanned pregnancy with a lady who is having a pre-existing diabetes. So that should be the goal of all the obstetricians and the diabetologists, because primarily they go to an obstetrician, and which is being followed by a diabetologist, that we should be emphasizing. And then the second word is need for speed. So that is what Madam has already emphasized, that need of speed is very important. Once it has happened, saving your skin, because there are medical legal implications associated, because one case can see that patient already 21 days are already there. And we know that the organization takes place in the first 10 weeks itself. So that lady is already exposed to hyperglycemia, and the recommendation says that the pregnancy should take place only after achieving an HbA1c of 6 without hypoglycemia or at least 6.5.
So HbA1c is definitely a criteria for about maintaining the patients on strictly on insulin and monitoring them. But same times in such situations we should have a written consent from the lady as well as from the family that anything can happen in future, and the monitoring is very important. This should be called to the patients in advance. So, to same question, management of pre-existing type 1 or type 2 pregnant lady.
This is again, if you already know the lady is type 1 or type 2, preconception counseling and a planned pregnancy, A1C target of less than 6.5%. If she is somebody on insulin, then obviously she can continue like I said. If it is somebody who is type 2 diabetes, then a part of preconception counseling has to be achieving type 2 targets, screening for pre-existing microvascular complications, especially retinopathy, because we know that in pregnancy, the retinopathy gets worsens if there is already a background retinopathy present. So any lady with type 1 or type 2 diabetes should definitely be screened for retinopathy before she gets pregnant. And then every trimester, if you picked up some background retinopathy, because risk of retinopathy progression is there in pregnancy, again screen her for nephropathy, screen her for cardiac disorders, also especially ladies who are beyond 40 years of age in late pregnancy, because risk of CVD is also very high at times. It's a prothrombotic state. Then when it comes to the glycemic management and HbA1c target of less than 6.5 before she conceives, throughout pregnancy try to target an HbA1c of 6% if that is achievable without significant hypoglycemia. It has to be insulin all the way. If this is a type 2 diabetic, then at least a month or two before she plans pregnancy, ideal is to switch her to insulin and maybe add on metformin if required. And then once she conceives, you can withdraw the metformin and continue on insulin. That's best, because it's the first few weeks, even before the pregnancy is confirmed. If that time she is on oral drugs, then again, like I said, teratogenesis, risk of congenital malformations is always there. So all the orals except metformin should be discontinued before she gets pregnant. And once she is pregnant, it has to be insulin all the way. For a type 2 diabetic, you need to understand that once the lady delivers, you can, as long as she's feeding during lactation, again in breast milk the drugs pass, including metformin. Bonus bridging that she was on, or the insulin pumps that most of the pregnant patients these days use.
Even in sometimes in the early phase of type 1 patient, in early part, around 1 month, sometimes I see there is no need for this post-pregnancy, which was only managed to the basal of insulin.
Yes.
Type of patient. Usually
Yeah, because in the first trimester there is a improvement in insulin sensitivity that occurs because of the estrogen progesterone hormones. The diabetogenic stress of the pregnancy hormones comes only in the second trimester. So insulin resistance is going to go up only in the second trimester, and that is why pure gestational diabetes, which is because of the insulin resistance on a background of chronic gestational diabetes, you see a sharp improvement in the insulin sensitivity in the first trimester. So for a type 1, you will see a reduction in doses that happens in the first trimester. Once she is proceeding to second trimester, as the hormones come in, the pregnancy hormones, the diabetogenic stress is going to go up and the insulin requirement goes up till about 36 weeks. At 36 weeks, again there is a plateauing of the insulin requirement. 36 to 38 weeks, you will not see a decline but a plateauing. And then once she delivers, you see a 20 to 40% fall in the insulin doses because the diabetogenic stress and the insulin resistance of the hormones is taken off. So the doses have to be accordingly tapered. So first trimester, doses will come down for a type 1 in pregnancy. Second and third trimester, doses will go up. And once she delivers, again a 20 to 40% decline in insulin doses will happen for a lady with type 1 diabetes.
One more question. Lactation is the only metformin can be given. What about the sulfonylurea?
Sulfonylurea also is not cleared in lactation, sir. There is some data from the UK on because their guidelines are pretty conservative and economy-based guidelines. So there is data on glyceride also being continuing because there's safety for metformin also that they advocate. But otherwise, it has been shown like sulfonylurea also passes in breast milk. Most of the drugs, that is why during lactation are still contraindicated. Metformin, even if it passes in breast milk, is not really shown to have any major effect on the baby. So that is why metformin can be used during lactation. Otherwise, it has to be insulin alone.
Okay. Sir, I would like to add to this on the lactation. It drugs glyceride, glucoside, and metformin. Some studies have shown that this can be used, but they say that they should be used at the lowest possible dose. That is very important because all drugs are going to pass the
Question. Yes, it's right. We have already. How much is the risk of having future type 2 diabetes in TDM, and how we can reduce that? That is how we have to follow advise the patients to what to do in future. Because many times what I see, patients come during TDM with us and then go to oncologist and no problem. So what we should be the approach of physician or
For that, my first appeal to our obstetrician colleagues, because what happens, patient has more faith in the obstetrician and they think that this diabetologist is a burden on us. Reason being that they want the pregnancy, they want the delivery, they want the healthy child, but they don't want to be diabetes. So, and that is supported by the obstetrician also. So they say the baby is delivered, this all happened because of your pregnancy, now you are off it, forget about anything, and it is happening practically every day and we all are seeing this. So my appeal to all that any diagnosed with GDM, delivered the baby should have a regular follow-up. Because it has been seen that if not in 6 months, 2 years or 3 years, definitely diabetes comes back. So if proper counseling, proper follow-up, proper regular investigations are not being done, the lady comes back to you with an experience of 9 or 9.5. So definitely counseling, a regular follow-up. The obstetrician should tell that my role is over now you follow up with the diabetologist. So that is very, very important.
Technically, that is not good. Obstetrician is not going to say this. So, what I do is, whenever patient comes first time to me, I always say, this is going to happen. You may be coming to me 1 or 2 or 3 or 4 times, but many times you forget. People are saying कि आपको diabetes हो रही है बाद में, अगर आप ऑपरेशन करेंगे, I write down prescription कि आपको कब तक pregnancy के बाद monitor कराना है.
Yes, that's correct.
Because initial visits I used to mention.
Another thing is that
how I do.
Even after the delivery, we have to follow up the patient, and of course the dose of insulin is definitely reduced, but we should continue for at least 6 months till the baby is being breastfed on insulin itself, so that a regular follow-up is being maintained. That is good for the patient also. So that should be done, and it is on our part that we make them educate that what is important. The gynecologist are not going to send the patient back to you.
But the main problem is, if patient is having the pure DDM, only then patient is not turned up. If patient is already having diabetes, then usually they have to come either with you or any other physician.
Actually, the pregnancy provides us as a window for giving very good education, because that is a time when the lady is very unable to one care provider. We are counseling to her. So that is basically the responsibility that the patient is coming to you, a diabetologist. That is the point where we have to educate them. That is a very good window to educate them about the future risk of diabetes. So this counseling, I said that the counseling has to go through all across, from puberty, pre-diabetes, pre-pregnancy, pregnancy, and post-pregnancy. So this continuum has to go all across the spectrum of the people's life.
So, 1 minute last time. So, that's the paper. 1 minute with all experts. First with the Shalu. Now, I will ask Madam also. Screening of the patient. Just 1 or 2 lines.
Screening has to be universal screening. Ideally, pre-conception before she plans pregnancy, that is the first time you should screen, because you can catch a lot of them with pre-diabetes or even sometimes over-diabetes right there and then. Target HbA1c less than 6.5% if she is already a pre-gestational diabetic. Again, at the first point in contact, when she's come to you, that is where DIPSI criteria 75 gram glucose, immaterial of whether she's fasting or not fasting. 2R value more than 140, she is a GDM. Even if it is pre-gestational diabetes, if you pick her up in the first trimester, do an HbA1c, that will tell you whether it is pre-gestational or it is still early diabetes. ADA clearly says, first trimester, even if the lady did not know she has diabetes, it used to be treated as pre-gestational diabetes, because this is when the organogenesis is happening. So that is where, again, if you pick it up early, this is the time you need to start insulin there and then. Only if it is second trimester or third trimester, then give her 2 weeks of MLT and lifestyle. Give her a target of fasting less than 90, 2R less than 120. If the targets are met, continue on that pathway. If the targets are not met, and so screening has to be every trimester. First point in contact in pregnancy, followed by second trimester and third trimester, and in high risk ladies even at 34 to 36 weeks.
Dr. Sharma, I will just what about the nutrition guidelines? Regarding management, what you would like to say regarding nutrition to your patients for managing
Nutrition.
nutrition?
There is a role of malnutrition as well as overnutrition, and this legacy goes on. So if there is perinatal malnutrition, then definitely it will develop the metabolic syndrome in the offspring. So that is important. A proper nutritional therapy with a nutritionist, where all micronutrients, macronutrients are taken care of, is to be planned, and that should be followed.
So many times, patient is not going. In India, it is not the concept. Patient will go to, because it is very difficult for obstetrician to send the patient to you, and now you will send to nutrition. Patient will not understand what is the way about.
So then it comes the carbohydrate restricted with good protein and minimal of fat. That should be the diet.
Now, Dr. Tiwari, what about exercise? Which exercise and when exercise and how much exercise?
Okay, so this is the most tricky part of the entire management. So basically, you have to go for the exercises which are safe, which are not strenuous. Always keep providing more exercise. Walking, which the lady can do, and as a pregnancy, and there are a lot of restrictions by the orthopedics also. So you have to understand that. So 30 minutes of mild to moderate exercise, brisk walking would be the thing to do. Some people also go for swimming also, that is also the exercise, but that is not possible in our setup. So it should be moderated, and the request is that to increase the activity rather than doing exercise.
So what other activity patients can do? Upper body exercises. This is very important. You have to explain. Upper body exercises are very safe. So sometimes patients may say कि डॉक्टर ने तो मुझे कहा है कि रेस्ट करना है. So in spite of this, we can say to the patient, just hand stretch, 10 times this, 10 times this, 20 times that. I used to say 5 times. Rest after the half an hour of breakfast, half an hour of lunch, half an hour of dinner. This is very good in controlling post-menstrual blood sugar. So many times this is a problem. This is a very safe exercise. Upper body exercise are safe. But even if the obstetrician has recommended bed rest, we can offer patients.
Add to this, I think these days everybody is getting so much of internet savvy, so there are so many yoga asanas which are available on the net. I think we should propagate that also because yogas are quite safe in pregnancy. And there are trained people who are yoga instructors who give the lessons on the net. You don't need to go anywhere, so you can always tell them that at least
Definitely, yoga has an important role, and safe yoga can be performed with the supervision, guidance of the explorers. Now, for you, what about the drug management? Just to revise.
So that's as we already said that it's the insulin should basically stress on insulin because that is the only drug which has been studied so widely and it is quite safe in pregnancy and we should propagate that only. And among the insulins, as Ma'am also said, drugs are also having found safe and effective of the which is there. But they are quite slightly costly, so we should start the movement to regular insulin. The LPH, that is the cheapest and the best drug for the pregnancy for the period. And as we already told, that metformin can be used as a complement, especially in resource-limited countries. And where we know that the patient are not educated and we have a risk of hypoglycemia more. So then in that case, the metformin can put the patient on metformin and just take care that the patient doesn't get hypoglycemia because of that. That we have to take care.
What about the premix insulin? You are using in pregnancy any kind?
No, that ideally should be basal bolus should be patient is ready to take insulin is better then we better safe take a basal bolus regimen.
So definitely, I have also seen patients who are on premix, they are not able to having the well control because they keep on having hypo as well as hypo as well as hyper and high entry. So basal bolus approach is ideal for this. Now I think we can ask any questions from the experts.
Just to add on, sir, normally the dictum for basal bolus use 50% and 50% pregnancy is the only state where the basal requirement eventually comes down, but the prandial requirement goes up. So this is where you will have around a 60% to 70% bolus requirement and hardly 30 to 40% with the basal requirement.
So it's a very interesting discussion. I'll add something. See, pregnancy in India is always accidental. Counseling are not done. Post-pregnancy, post-delivery, my advice to my patients, please adopt contraceptive measures. Repeated during the pregnancy, repeated giving and repeated. So contraceptive measures should be adopted and repeated during the pregnancy should stop. This counseling should come to the husband.
Sir, accepted part of preconception counseling, a very important part is contraception. So between two pregnancies, contraception has to be offered even if it is a pre-gestational, a type 1 or a type 2 young diabetic. Even when she is not planning a pregnancy, I think just one line warning her not to plan pregnancy or to let you know before she plans a pregnancy, explaining her the importance of preconception counseling, preconception control, discontinuing orals is very important. So any young lady who is a known diabetic type 1 or type 2 should be counseled on contraception and avoiding an unplanned pregnancy. That is very important and choice of contraception has to be offered. That is very, very important part of preconception counseling.
The spouse should be involved at every stage. After marriage, I think the counseling should be for both the people. husband as well as wife, because decision has to be taken with two individuals when it comes to the conception. So the husband should always be involved in the concept. So I always tell my patients, please bring your husband also, bring not with him. That is a very nice for
One very important thing which I get into notice, patients who are already diabetic receiving very high dose of insulin than those patients who are gestational diabetic. So it is, we have to start with a higher dose to those patients who reach the target. Otherwise, start with a lower dose, they keep struggling, and it takes a longer time for them to reach the target of 90. That's another point.
Absolutely, sir. Very, very important. Usually, pre-gestational diabetics will need a much higher dose of basal bolus total insulin. Pure gestational diabetes, which you are picking up beyond 28 to 30 weeks, mostly you will see only postprandial hyperglycemia. If it is a pure gestational diabetic, so there sometimes you don't even need a basal insulin, only you need the bolus insulin there for the postprandial control. But if you are seeing a spike in the fastings, that is where a basal has to be added. But for a pre-gestational, a much higher, almost 40% higher dose of insulin is required compared to a gestational diabetes.
Blood glucose level is coming down. So, as you told, we start with intensive insulin therapy. So, what we need to at the start, what we need to advise, we have to continue with the same insulin therapy, or we have to reduce. And if we need to reduce, then by what percentage?
Most of the patients don't require this. There's complete reversal of what we say sugars are completely normal and they don't require insulin at all. But that only the regular sugar monitoring will take, because there's a chance that she was already pre-diabetic and now because has got a bit over diabetes. So there is always a chance that she is having type 2 diabetes. So only blood sugar levels will tell us what the insulin will be.
Follow when we are making the discharge, is there any guideline that we need to reduce the insulin dose?
See, if it is a pre-gestational diabetes, that means somebody who already has type 1 or type 2 diabetes, you know that the diabetes is going to continue. So for this woman, the targets, number one, post-delivery change to the normal non-pregnant targets. That means a fasting between 100 to 110, 120, maximum to 130, and 2 hours between 140 to 180. So tell her that now the targets have changed. Secondly, like I said, the insulin resistance that was induced by the pregnancy hormones is over. The placenta is out. So obviously you will see a 20 to 40% reduction in the insulin requirement for this lady. She will go back to almost her pre-pregnancy insulin doses. So this is where the last trimester doses, whatever she was taking, based on the SMBG for the next 1 or 2 days post-delivery that you have done, you will get a fair idea. So there's no hard and fixed rule, but you can reduce the basal by 20% and boluses can be decided based on the SMBG targets. That should be your discharge, and then you can explain the insulin dose titration based on the SMBG and tell her to monitor her glucose levels and accordingly change her bolus doses. So that should be the discharge prescription, and then once she comes back to you for review, that is where based on SMBG you can fix up the doses. And always remember, whenever your patient is on an insulin intensive regime, which means a basal bolus or even a twice daily premix, she should be taught self-titration, because every time the patient cannot keep coming back to you, and the number of patients that we see, it is practically and physically not possible for any doctor to titrate insulin doses for so many patients. So an important part of continuing insulin is teaching the patient the importance of SMBG and titrating the insulin doses. You need to just guide her how to increase or reduce doses based on the SMBG levels.
What I usually practice, I tell my patients that if you find that sugars are on the low side, you reduce the dose. But if it's deciding on that, that please don't do anything. Because they keep on fiddling with that insulin, and then when they come back, it's a problem. But yes, self-hydration is very important. The patient is intelligent enough. That's the best thing which we should do.
So, no questions that we can conclude. Thank you, everyone who active participated in this.
Now I request our moderator, Dr. Prahlad Chawla, to present token of appreciation to our panelists. And I request Dr. Ajay Gupta to please come on stage and present the token of appreciation to our moderator, Dr. Prahlad Chawla. Moving forward with same enthusiasm to our next session, which is a panel discussion on diabetes and lifestyle. I now invite our moderator for this session, Dr. Saurabh Srivastava, Professor and Head Department of Medical Sciences, Institute of Medical Sciences.
So we start off with the last panel of dialogue and diabetes. There are many changes. Dr. Saket could not make up. Dr. Divya is also not here. So we are left up with the two panelists. Dr. Girish Kurana, I invite him on that. Dr. Girish Kurana is founder and medical director of Vidya Medical Center, Delhi and NCR. He is secretary educated in district chapter Haryana. He is vice chairman RCI Delhi chapter. He has more than 30 publications in depth, national and international. And our second panelist is Dr. Abhishek Arun. He is consultant diabetologist and metabolic physician, Center for Hospital and Vishuddha Diabetes Clinic, Lucknow. He is clinical research head of MD Hospital and Research Center, Lucknow. He is visiting faculty Department of Diabetes, Physiology and Metabolism, CMC, Bangalore. He is speaker in various conferences and more than 50 publications to his credit. So we start off with the last panel of this session, and the topic is diabetes and lifestyle. हम लाइफस्टाइल के बारे में बहुत सारी बातें करते हैं और हम हमेशा ये कहते हैं कि लाइफस्टाइल अगर हमारी सही होगी तो हम डायबिटीज से बच जाएंगे. डायबिटीज इज अ लाइफस्टाइल डिसऑर्डर. एक्चुअली लाइफस्टाइल है क्या? लाइफस्टाइल वो है जो हम जिस तरह से अपनी जिंदगी जीते हैं, दैट इज लाइफस्टाइल. हम क्या खाते हैं, कब खाते हैं, किस समय खाते हैं, कितनी एक्सरसाइज करते हैं, कैसे सोते हैं, कितने समय सोते हैं, ऑल दीज थिंग्स कम्स अंडर लाइफस्टाइल. हम कितना स्ट्रेस लेते हैं, हम जब बीमार होते हैं तब क्या करते हैं, हम अगर शिफ्ट ड्यूटीज में काम करते हैं तो क्या करते हैं, ये सारी चीजें मिलकर एक लाइफस्टाइल बनाती हैं. सो हम इस लाइफस्टाइल डिसऑर्डर के बारे में और फर्दर जानने की कोशिश करते हैं कि हाउ वी कैन मैनेज डायबिटीज और लाइफस्टाइल. सो माय फर्स्ट क्वेश्चन टू डॉक्टर अभिषेक इज दैट, अभिषेक आप मुझे ये बताइए कि ये कार्बोहाइड्रेट, प्रोटीन, फैट ये सब क्या है और क्या चीजें हैं, क्या माइक्रोन्यूट्रिएंट्स होते हैं, क्या मैक्रोन्यूट्रिएंट्स होते हैं, कैलोरी क्या है, हमें अपनी प्लेट कैसे सजानी चाहिए खाने की कि उसमें कितना प्रोटीन रहे, कितना कार्बोहाइड्रेट रहे, कितना फैट रहे, और वो प्लेट हमारी कैसे इतनी अच्छी हो कि वो हमें बेहतर जिंदगी प्रोवाइड कर सके और डायबिटीज से बचा सके. डॉक्टर अभिषेक.
So, to highlight, so the medical nutrition that we actually all know diabetes. And so as we talk about medical nutrition therapy, we actually talk about the food we eat. Initially, there were a lot of buzz around various kind of fat diets which have been given to the patients. Apart from that, dietitian tailored and customized nutrition charts which have been given to individual patients have been very of much buzz a lot. But if we talk about the balanced diet with the ideal patients should take, the AD guidelines and even the SI guidelines recommend that the patient should be having around 55 to 60% carbohydrate intake, which is one of the macronutrients in the diet. Apart from that, the carbohydrate that the patient is taking should be more complex in nature. It should be more complex carbohydrates rather than simple sugars or simple carbohydrates. The person should also be told to take food with lower glycemic index. So the patient should be told about the glycemic index and with the individual food items might be having. So the patient is actually identified and told about each item of each macronutrient is having a low glycemic index, and based on that, they have to choose the right kind of carbohydrate in their diet. Talking about this basically regarding the carbohydrate. Apart from that, going back to the protein, which are very, very important aspects, 20% constitution in a diet being made needs to be to the protein, which is often missed. And the patient should be again counseled regarding the intake of protein much in the diet. The protein intake predominantly comes in vegetarian nutrition through the pulses like yogurt. But the other sources, non-vegetarian sources of protein, patients should be told to eat the meat, meat, fish, and they should be discouraged to eat the red meat at all costs. The fat part, again, it is a macronutrient, and the fat should be limited to around 20 to 30% in the diet. And the patient should be told that they should be taking more of monoinsaturated fatty acid and polyunsaturated fatty acid rather than taking more saturated fatty acid in that, which should be limited to less than 10%. Apart from that, dietary fiber intake should be encouraged most of the time. It should be around 25 to 40 grams in daily diet, which is very, very important. So apart from these macronutrients, the patient should also be told to take more amount of micronutrients in the form of various fruits, nuts, and non-starch vegetables, which should actually be the ones which will supplement the micronutrient deficiency in that particular individual. All in all, there are two ways which we can tell the patients in a modern day world where they don't want to go for customized diet plan. One is the plate method, wherein you have to divide the plate firstly into two halves, and the first 50% contain the non-starchy vegetables, and the rest 25% will contain predominantly the carbohydrate items, and the rest 25% will be the protein. Apart from that, the patient can also take non-fat dairy items, and a lot of water should be advocated, and the meal timing is equally important, which the patient needs to be told. Once we talk about the limitation of calories, it needs to be told to the patient if he or she has been told to take around 1600 calories in a day, he should not be taking that 1600 calories at one. They have to be allocating that diet into different portion size, and they have to take it regular intervals at different points of time in the day. Apart from that, the second major method which is often used and recommended by a lot of guidelines is the portion control method, where the patient is being told that they can eat different kinds of food items, but they have to limit the portion size which they are eating. And this is also one of the ways by which they can really control their blood sugars, especially the postprandial blood sugars, which is elevated on intake of a good amount of carbs in their diet.
So, Dr. Abhishek, you have very actually talked about all the aspects of food intake. जैसा कि हम सभी जानते हैं कि पानी के अलावा कोई भी चीज लेते हैं उसमें कैलोरी होती है, एंड दैट कैलोरी इंक्रीजेस योर ब्लड शुगर लेवल्स. सो वो एक लिमिटेड अमाउंट पे लेना है, जैसा कि आपने बताया कि प्लेट को हम डिवाइड करके लें, जिसमें कि मेजर पार्ट हमारा कार्बोहाइड्रेट नहीं होना चाहिए, 25% कार्बोहाइड्रेट होना चाहिए, 25% फैट होना चाहिए, और फैट में भी सैचुरेटेड फैट्स आर नॉट टू बी टेकन. लेकिन फिर वही बात है, कल हम जो डिस्कस कर रहे थे कि देसी घी एक ऐसी चीज होती है जिसको क्या ले सकते हैं, जो कि कभी भी ऐसा नहीं कहा गया कि हम उसको नहीं ले सकते, बट ये है कि उसको फ्राई नहीं करना चाहिए. तो देसी के पराठे नुकसान कर सकते हैं, बट देसी की दाल में नुकसान नहीं करना चाहिए. ठीक है. अब डॉक्टर गिरीश सर, आप मुझे कुछ इस बारे में बताएं कि अगर हम डिफरेंट टाइम जोन में ट्रेवल करते हैं तो हम अपने डाइटिंग को कैसे मैनेज करें. हम यहाँ से जा रहे हैं, अमेरिका जा रहे हैं, या एक जोन से इंडिया में, या एक जोन से दूसरे जोन में जाए तो थोड़ा समय तो बदल ही जाता है. अगर फार ईस्ट से फार दस जाए तो काफी खतरा रहता है. तो हम इसको कैसे मैनेज करें और क्या, हाउ टू मैनेज डाइटिंग ट्रेवल.
Considering the traveling scenario these days, most of the people think you are traveling for some reasons or the other to various destinations. So the role of regular diabetes becomes very crucial. And particularly when we cross more than 5 time zones, and that too in east or westward direction. If you travel from north to south or south, we need not have much changes of losing schedule. But when we cross from eastward direction or westward direction, we have to take care of so many things. But before that, I would like to say that before anybody travels, he has to look for so many things. He has to decide before. He has to keep track of his general instructions and then medical instructions, which are equally important. He has to take a list of the reasons which he has to take along. The type of insulin, the quantity of insulin which is sent there, and when one should go, he should take at least double the amount of medicine he needs for his treatment. And that too, we should keep it two different compartments. One is carry bag and one is suitcase. Because sometimes you lose also. And you should be aware of the type of drugs available in the country where you are going, the type of insulin or the medicines. You should have a proper prescription from the doctor, and you should have a proper seal compartment of boxes, and you should also check with the airlines that whether you need to get screened through the system if you are wearing a pump or other medicine which you need to get screened by the access. Though most of the times they are not, they don't affect it. And secondly, once you are through this, you have all the things ready with you. You should also ask your airlines for your meals preferences. And you should also carry some homemade snacks, ready-made snacks in case you get hypoglycemia of that way. So then comes the question of titration of medicines. Because once we travel to eastward zone, there is hardly any changes in type 2 medicines. Patients who are oral medicine, they can take it, but we have less time. We use the age early when we travel eastward. So patients who are on insulin, they have to take lesser amount of insulin in that case. And when you go westward, you gain a day and you need more insulin. So preferably, patient should be on basal bolus regime. If he has time, he can shift to basal bolus. But if patient is on pre-mixed regime, suppose NPH and Lentus, NPH or Lentus or short-acting insulin, then he has to decide the dose of insulin according to the way he travels. Suppose one is traveling to US and he is on NPH and McCartney or some regular insulin. So in that case, he will need one extra dose of short-acting insulin in between. And once he reaches at the destination, he can take half more dose of basal insulin. And by the time he catches that time, he should wear the both watches, Indian watch as well as the time which is arriving. And then he can increase the dose of east. Similarly, when he is on the eastward direction, patient has to miss one dose of NPH, he can take half dose of NPH rather than full dose, and by the next day he can shift back to his normal dose. But in case patient is on oral drugs, suppose something like urea or metformin, and he is going to US, it is better to skip one dose and have hyperglycemia for 4-6 hours rather than taking more medicines and landing a bit further. And you can always check your blood sugar on the board, though the blood sugar levels are little less as shown in the glucometer at a higher altitude. But you can know how the symptoms you are suffering from if there is any hyperglycemia. Secondly, you should keep your body stretched, keep on walking, take plenty of fluids on the board, and take small snacks in between. You should have carbohydrates, snacks in between every 2 to 3 hours and to take plenty of fluids. So this is how.
Thank you, Dr. Girish. You have very well said that while traveling north to south, there is not much change, but if you are traveling from east or west, then there is major change in your dosing and your schedule. Insulin, if you are going westwards, will be more will be required. If you are going eastward, less will be required. Similarly, the dose of purchase is to be adjusted.
One or so 2 points I would like to add over here. If patient is on insulin pump, so when you have started your journey, the patient that aeroplane is flying, we should take out that data because there is a pressure changes and it can lead to less action of insulin. Once the plane starts, then you can add it. And number two, the place where you are going, suppose it is a hot climate, you should be aware of that. There the insulin degradation chances are higher, so you should carry insulin in water pouches.
So, these are the things which should be kept in mind while traveling, and it is very important because traveling also comes in our lifestyle, and now our lifestyle has so much changed that right now I am here, next month the person can be anywhere in the world. So this is again a lifestyle type of things which is to be taken care of. Now coming again to Dr. Abhishek, what are the guidelines for exercise in a diet?
So, after discussing the diet part,
lifestyle of his exercise, and which is another important patient education, all elements of the outlet. So what we always tell, even the guidelines advocate, is 30 minutes of brisk walking at least 5 times a day. That makes it 150 minutes of exercise in a week. Now that is the minimum recommendation of the diabetic patient needs to follow. Apart from that, the exercise needs to be customized as per the patient requirement, based on the physical needs, based on the other aspects like the patient to be, patient to be sarcopenia, whether he's having any other comorbidities alongside, can be tailored along. So what we also recommend is they can, even all those healthy patients who really want to lose a lot of weight, they can go for either a combination of aerobic exercises along with resistance training or low resistance training, depending on the patient profile as well. Other exercise time needs to be and also be advised to the patient, based on the patient. But the easiest one, what I always tell them is copy, but all of them can be argued, and that is what the guidelines say.
Thank you, Dr. K. तो भैया जो एक बार कहावत है ना कि अगर दौड़ सकते हो तो दौड़ो, दौड़ नहीं सकते तो चलो, चल नहीं सकते तो चलो, मतलब you have to work because your calories need to be burned out. So exercise plays a major role in the management of diabetes. So that's what taken care of. Again, जब हम डायबिटीज हमें होती है तो लाइफस्टाइल में एक बार ये भी आता है कि हम कभी ना कभी बीमार हो जाते हैं. तो डॉक्टर गिरीश, व्हाट आर 6 day मैनेजमेंट ऑफ डायबिटीज? अगर हम बीमार पड़ जाए तो उसमें हमारे लाइफस्टाइल में क्या क्या चीजें चाहिए और हमें क्या करना चाहिए? व्हाट आर 6 day मैनेजमेंट ऑफ डायबिटीज?
Before I start this sick day, I will ask you about exercise. Exercise is equivalent to 1 kg. It reduces HbA1c by 1%. So you can ask your patient that if you exercise, you will need 1 less kg, otherwise you will need 1 more. Because it is going to add on your weight, resistance will go down.
That can be a motivational part for the patient, that you will miss one pill if you exercise. It is equivalent to.
So sick day rules, they are made specifically to take care of complications during sickness of diabetic patients. And it becomes very important, particularly we have seen COVID, when patients are all alone and they have to manage themselves. So it is very relevant these days, especially. So sick day rules, they have been they are a little bit different for type 1 and type 2 patients. It is to make a patient aware what he has to do during his sickness. He has to avoid sickness on the forefront by taking injections of flu and pneumococcal vaccines. We all know that the few diseases which lead to more problems are flu, COVID, pneumonia, bronchitis, abscesses, UTIs. They are the common problems and we can take care before him. And once patient becomes sick, there are chances of hyperglycemia because of increasing counter-regulatory hormones, and which make insulin resistant to work to lower the sugar. So the patient has to take care of. If we take the mnemonic SICK, S-I-C-K, SICK rule, and if we take one by one, S is for sugar level. Patient has to monitor his sugar levels every 4 hours. And if sugars are high, more than 300, then he can make it every 2 hours. Irrespective of day and night, he has to maintain. And he has to take more of fluids. I is for insulin and illness. He has to take the care of illness, what is the cause of illness and appropriate treatment. And insulin means he has to take continuous injection, he has to take, he has not to miss the dose, whether it is oral medicines or insulin. And C is for carbohydrate. Patient has to take at least simple carbohydrates. If his tummy is not good, he can take 50 grams of carbohydrates every 3 to 4 hours. And he has to take fluids 150 to 180 ml per hour. And K is for ketones. Patient has to take care of his ketones if he is on insulin. Patient should monitor his urine
reporting ketone levels or blood ketones level. Though blood ketones are better to answer because of Meyer's beta-hydroxybutyrate acid and urine Meyer's acetone and acetoacetic acid, which takes more time to disappear and appear. And patients who are on oral medicines, if they are sick, they are not taking appropriate fluids, then they should avoid few medicines like metformin because of risk of ketoacidosis, SGLT2 inhibitors because of risk of decay, GLP-1 receptor agonist, this should be avoided. And if patients are on ARBs, ACE inhibitors, these drugs should not be taken. Patients who are non-steroidal anti-inflammatory drugs, they also should not be given in these patients. And if patient has got high level of blood sugar, then we can give correction dose of insulin who are already on insulin. And if patient is not able to eat in spite of antiemetics and in spite of small carbohydrate meals, they can be put on IV line, and there you have to put the patient on insulin. And according to the ketones level, we have to increase the insulin dose by 10, 15 or 20% depending upon the level of ketones, whether they are mild, moderate or severe. And accordingly, we can manage the glucose level. Once the patient is controlled, is out of sickness, again we can put him back on the routine medicines. During the illness, patient has to take simple carbohydrates, or he can take more sugary fluids, simple fruit juices or cereals, small snacks, some salt crackers, which are easy to digest. So if you can have a small menu of 50 grams of carbohydrates for a patient in the form of one bowl of cereals or soup or fruit juice or curd, something which is palatable to him. We can give him every 3 to 4 months. This is how we manage CK roots. So, the people answered that you have to remember SICK, SICK, and that will answer all your questions. So, SICK is to be remembered. Now, coming again to Dr. Abhishek. Now, alcohol has also become a part of lifestyle. So, what are the guidelines? How safe is alcohol? And how alcohol affects life? Dr. Abhishek.
So, the guidelines regarding the alcohol intake are pretty much clear. Now, there are various guidelines including ADA, IDM, and NHS guidelines regarding the minimum amount which actually allowed for male or female. For a female, it is around 1 gram per day. For a male, it is around. And the amount of alcohol which needs to be taken is around 20 ml. That is very, very important. The nice guideline also say around 15 units of alcohol every year. And that is very, very important because that covers how much limits and alcohol is found in body particularly and actually helps with controlling, and it is not very bad for the blood sugar level. If the patient is found addicted, this can lead to severe anxiety, which can be devastating patients. Sometimes they combine different kind of drugs. So they make a lot of cocktails. So binge drinking and taking a lot of cocktails can also be deadly, especially for the diabetic patients. So taking simple 1 gram at a time, that is moderation, and limiting the quantity as per the guidelines to weekly limit should be the ideal way of going ahead rather than taking too much at a time. That should be the ideal way. It should be explained to the patient. Because that is the basic question that the patient often asks you or us as well. कि डॉक्टर साहब कितना कभी कभी that's when you ask वो कभी कभी की frequency कितनी है, and then they'll tell you it is around 5 times a week and or even more than that sometimes. And you also need to ask them about the amount of alcohol in ml, whatever they are able to understand, ounces, units, whatever is best restricted for the patient, how much they are able to take on a daily basis, are they taking too much? Because that's something which is very important. You have to also look for the underlying liver disease. The patient having an alcoholic liver disease. So if the patient having alcoholic liver disease, then actually you need to tell them to go for the cessation of alcohol and also because you actually need to consider the comorbidities which are associated with diabetes, not only diabetes. Because most of the patients, you will also be seeing other comorbidities which needs to be simultaneously addressed. Because of this time, you need to actually limit the alcohol to zero, depending on the patient. So that is also very, very important. Apart from the guidelines, that's basically only for simple travelers who are not having any complication or any other comorbidities.
So, said alcohol can be taken, but guidelines are guidelines. They are there to guide you, but not the compulsion that it is to be done. But as very well said that it is personalized. You have to see a patient individually and then advise him that whether he can take alcohol or not. Coming again to Dr. Girish, हमारा आज का लाइफस्टाइल ऐसा है कि बहुत सारे लोग शिफ्ट में काम करते हैं, डॉक्टर्स भी बहुत सारे शिफ्ट में काम करते हैं, नर्सिंग स्टाफ मोस्टली शिफ्ट में काम करता है. तो व्हाट इज द गाइडलाइन फॉर मैनेजमेंट ऑफ डायबिटीज शिफ्ट वर्कर? शिफ्ट वर्कर अपने आप को कैसे एडजस्ट करे कि वो अपने डायबिटीज को मैनेज भी कर ले, अपनी शिफ्ट भी मैनेज कर ले.
Shift working is nowadays very common. Most of the students are part of their work and shift duties. And I was going through literature and they say if you work after 6 p.m., that shift is known as graveyard shift. So I was surprised to see that because only 16% of the people they serve after 6 p.m. to 8 a.m. 84% of the population they work within the daytime. And this is the shift which is more prone for diabetes and other diseases also like cancers and all other diseases. But 9% to 24% persons seem to be found diabetic after they indulge in shift duties because of the lifestyle, because of the work, because of the eating behavior they have, because of their sleep pattern and so on. So these patients who are new, they are non-diabetic, 9 to 24% of patients they become diabetic. Again, depends which type of shift you are working. Whether you are working in morning, evening, night type of shift or a fixed shift. A person who works in a fixed shift, suppose a person is working in night duty for months together, he is not likely to have more chances of diabetic as compared to a person who is working on alternate days, something like that. So there are no definite guidelines for this, but we have some recommendations to prevent and to manage diabetes in some of these patients. So these patients they should take care of their needs, they should take care of their medicines, their exercise routine, and proper sleep. These are the 4 important parameters. So one is diet. These patients they are asked to take principal meals at 12 and 6 p.m. So they should have major meals by this time, and by the time they come back from duty in the morning, at that time they should not take major meal. They should have a night snack. Number one. Number 2, in between, if they feel hungry, they should not go for a vending machine and take the snacks. They should get a ready-made snack from their home. It should be of simple, complex carbohydrates or some proteins. They can have some wheat toast or some biscuits, like that. But they should not go for things which are ready available in the canteen and they are more fatty. And number 3, and during the duties, they should find some time to walk around. Because again, there are 2 types of people, one who are doing the work all around and one who have a sitting job. So person who have a sitting job, they should roam around in between. They should do some stretch exercise. And once they come back home, they go to sleep, they should have a conducive environment to sleep. They should avoid all mobile gadgets and they should not take any caffeine drink before going to sleep, at least 3 to 4 hours before sleep. And they should then go for a room where there should be enough darkness because our eyes they respond only to darkness because our hypoxic helpless pituitary axis it works on the retinal exposure. So these are the 4 points one should take care of. And the last but not the least is the psychological aspect. Most of the patients they become depressed when they are on high duties together. And one should look for those things also. Females they are more likely to get depressions who are on high duties. Even in our health department also, nurses and they are more likely to affected than other professionals. Police personnel they are more likely to affect because of other psychological stresses. So one should take care of that part as well as management of these two factors. This is how to manage. Apart from regular medicines which we have to take.
And those shift workers have to take care of their meals and they should also exercise. इससे जुड़ा हुआ एक और क्वेश्चन any of the panelists can answer. How much hours of sleep is required? Whether sleep deprivation is responsible for dampening or metabolic disorder.
How much sleep is required?
How much sleep should be there? At least minimum amount of sleep is required for a person. Sleep is available metabolic disorder.
Sleep quantity of sleep increases with age. Ideally, it should be around 6 hours minimum, but with age it decreases and it should be quality sleep. Persons who are on night shifts, they have links with micro sleep. They sleep for a few minutes. So that affects their social life also. Social life is very much affected in persons who are on night shifts. They keep on sleeping every time they are not able to attend the social functions. But ideally 5 to 6 hours is enough to maintain your hormone levels, which is necessary for growth.
So we have discussed about diet, we have discussed about exercise, we have discussed about alcohol use, we have discussed about sleep pattern, we have discussed about management during travel, sick day management and shift workers. Now one word about chrononutrition. अगर आप लोग कोई भी बताएं, what is chrononutrition? क्या हम कुछ इस पे बात कर सकते हैं?
Chrononutrition is basically following the biological diet and eating at the right time. So if you're not following that biological diet, so you are more likely to get distress. That's the basic reason for that is the amount of hormone which has been actually released in your body as per your biological clock also varies. So it is ideal to take the calories which is good in amount, especially at the start of the day, then probably going down and down and take the last meal as ideal way, because if someone is doing that, he's actually following his or her biological clock, and likewise he's able to limit the blood sugar levels just by diet intervention. This should be the first step, rather than telling only them about the amount of calories they should be taking. The applying the principles of chronomedicine and chronobiology alongside and helping them to what amount of foods needs to be taken at one time will also help in bringing down the blood sugar significantly.
Thank you, Dr. Abhishek. It has been said that eat like a king. राजा की तरह खाइए, राजकुमार की तरह दोपहर का खाना खाइए और रात में सोते समय बिल्कुल भिखारी की तरह खाइए. That
will be apt for having a good option for being away from the metabolic disorders. So most of our things are Lord by Sun. तो सूरज के साथ साथ अपना जिंदगी को जितना
align कर लेंगे उतना ज्यादा आप इन metabolic disorder से दूर रहेंगे. That is the crux of chrononutrition. जैसा कि हमारे ऋषि मुनि कहा करते थे, that was the thing. So to summarize the panel discussion, we have talked about diet. Carbohydrate should be less. Protein amount should be around 25%. Around 25%. 25% should be around fat. Saturated fat should be avoided. You can eat fruits. The complex carbohydrates are better as compared to simple sugars. Exercise is required, and at least 150 minutes per week of exercise is essential for a healthy lifestyle. Adequate amount of sleep is required. Minimum 6 hours sleep is very much important, and it is said that around 8 hours sleep should be there. If you are traveling across the time zones, then you should take care of your drugs, whatever drugs you are taking, and that time zone travel is when you are traveling around east or west, not from north to south. Then around sick day, you have to manage your diabetes by remembering sick. You have to take care of your glycemia, which is very much important. And if you are a shift worker, that is very important that you should not be munching all the time. And during night hours, you should not be always taking a cup of coffee, a cup of drink or something munching all the time. That is not good for your metabolic control. So I think any questions from the audience? Panelists are there?
So for a male and a female, it is different. That is around 30 ml once daily for a female and 30 ml twice daily for a male. So 2 glasses, 30 ml for a male, and that too. Yes, one day. Yes. And now that it's basically the whiskey amount. The If you talk about beer, it has to be 1 pint of beer, the medium side bottle, and then for the other wine, they say it, around 100 to 150 ml. So that is slightly larger in amount. So for basically whiskey or mortal alcohol, that is around 30 ml. 30 ml.
30 ml of whiskey.
Yes, that's another important question. So we have not touched upon over here the once we are taking different kinds of food and even alcohol, what alterations do we need to do with the medications which the patient is taking? So very likely pointed out, once the patient is taking metformin, if you're taking uh, binge alcohol or even alcohol on any routine basis, this is actually found to be interfere, and the patient can have severe gastritis, severe vomiting. Some patients can even land in acidosis at times because of that. So we should also always tell them that there has to be a gap once they are taking it, and if it is too close, better not to take that drug at that time. Yes, it can cause disulfiram like that.
Yeah, anti-abuse type of action. So that is also very
Plus
important.
hypoglycemic
And also
awareness is
similarly, we
reduced.
have to keep mind we are giving DPP-4 inhibitors, especially sitagliptin. So it was initially when the sitagliptin was launched, it was one of the precaution was
Yes, sir.
not to be combined with alcohol intake.
It has to be medicine first. But if you have taken medicine first, then there has to be a gap of around 1 to 2 hours, at least. Otherwise, there can be a reaction, as rightly pointed out by sir.
Question? Is there some question? Sir, go mic there.
Okay. What are the guidelines for those who are having comorbid states? Can we really ask them to go ahead with their exercise? What are the guidelines we should actually follow if a person has a comorbid states? Whatever you are telling are the early diabetics or even the mid stage of the disease.
What type of comorbidities you are speaking about?
Say somebody having cardiac disease or in between, let us say heart failure with mid ejection fraction or even a preserved
So,
ejection fraction like that.
So all these patients, the amount of food which they are taking, the amount of water they are taking, the other alcohol or any other things, it is actually customized and it needs to be individualized as per the patient needs and the profile of the patient, because the patient's shape and size might be different. The profile the patient blood pressure, the glycemic profile, other liver parameters, renal parameters can all be different. Based on the patient's individual profile, you need to tailor it out in all such cases once you are making a complete prescription for the patient. It is actually one size cannot fit all. So you need to really address to that patient. It should be patient-centric rather than disease-centric.
So one thing I can add that before writing medicine, you should write how much diet the patient should take, how much exercise he should do, and then third thing should be the drug. That's how this lifestyle disorder should be tackled. So this should come as a part of prescription that this much kilocalorie diet is required, this much exercise is required, and then comes the first drug, that is whether metformin can be given, then metformin or insulin or sulfonylurea or something like that. So first two lines should be, in diabetic patient, first two lines should be about diet and exercise, and then there's a role of drugs to be given.
30 minutes walk every day plus 10 minutes of stretch exercise. This should be the minimum. Maximum it is up to him. And depending upon, as Dr. Saab has asked, if patient is suffering from heart failure, he will not be able to walk. So it is more important to control heart failure rather than to take care of exercise and reduce his.
So that is the thing, that it is to be personalized medicine.
Yeah.
It should be personalized
even
for
we
every
have
person.
yoga exercises which can reduce your HbA1c, which can be done if patient is not able to move around much, if he has not easy to walk for him. Thank you.
So if there are no more questions, we can finish up with this panel discussion. Over to organizers.
Thank you, sir, for such an enlightening session. And now I request our moderator, Dr. Saurabh Srivastav, to please present token of appreciation to our panelists.
हैंग होता है मैम अभी कोई नहीं रहा
Moving forward to our next session, Quest to put peptide in a pill, development and clinical journey of oral semaglutide. I would now like to invite our chairperson for the session, Dr. S.K. Sahu, Senior Consultant, Apollo Hospital, Noida, and Dr. Abha Sharma, Assistant Professor in University College of Medical Sciences and GTB Hospital, Delhi. Please come on stage and grace the session. I now request our chairpersons to please introduce and welcome our speaker, Dr. Sameer Agarwal.
Good evening. Good evening, everybody. It's a great honor for me to introduce our next speaker, who's Professor Dr. Sameer Agarwal. He is head of endocrinology and metabolism at Apex Plus Super Specialty Hospital, Rohtak, Haryana. He is DM endocrinology from AIMS and a president at Society for Promotion of Education in Endocrinology and Diabetes. He is MCI recognized PG teacher, has publications in national and international journals of repute. He is recipient of A.V. Gandhi Award for Best Clinical Acumen in Endocrinology. His main areas of interest are metabolic bone disease, osteoporosis, pregnancy, and hormonal disorders. He is editor in Insulin Manual, editor in Manual on Pregnancy and Thyroid Disease, and editor of Clinical Manual on SGLT2 inhibitors. So please welcome Professor Dr. Sameer Agrawal.
I think this is a good innovation in management of type 2 diabetes, oral GLP analog. I think GLP analogs are still underused in management of type 2 diabetes. We all know from our basic physiology teaching that GLP and GIP, these are two gut hormones produced from K cells and L cells from the intestine. One is GIP, which is glucose-dependent insulinotropic peptide, and second is glucagon-like peptide. But the scientists are working more on GLP. Various studies have shown that GIP, or glucose-dependent insulinotropic peptide, doesn't lead on to any significant increase in insulin secretion from the beta cells, or any decrease in the glucagon secretion which happens with GLP and not with GIP during the phase of hyperglycemia, or any pleiotropic benefits like weight loss, increased satiety, decreased gastric emptying. So the properties seen by GLP, or glucagon-like peptide, they increase the insulin secretion from the beta cells. They decrease the glucagon secretion from the alpha cells, particularly for type 2 diabetic patients. And definitely they have some pleiotropic benefits like weight loss, improvement in the satiety. The problem with GLP is that it's being degraded into the blood. It has a very short half-life. So there are innovations where they have developed GLP analogs which are not being degraded. So you have two options in management of type 2 diabetes. Either you use a GLP analog like semaglutide or liraglutide or dulaglutide, which is not being degraded. Or you can use a DPP4 inhibitor, which can prevent the degradation of this GLP. So advantages with DPP4, you know, these are oral agents. GLPs, these are injectable agents. These are costly agents. But whatever data we have with GLP is that they significantly decreased HbA1c, and simultaneously they cause weight loss. So they are very good molecules for management of type 2 diabetes. They are very good add-on drugs. You can use it even in advanced stage of type 2 diabetes, where patients are not being controlled with diet, lifestyle, or combination of oral drugs, even the patients who are on insulin. So we have been using GLP analogs like exenatide, liraglutide, dulaglutide since long. But not many patients of type 2 diabetes, they want to be on injectable drugs. And as all of you have seen in your clinical practice, most of type 2 diabetic patients would like to have minimal injectable drugs. So do we have an oral GLP with Rybelsus or semaglutide? I think this is a good innovation where now we have an oral GLP. And you must have observed in your practice also, once you suggest patient any oral molecule, the acceptability is definitely higher as compared to injectable molecule. But only time will tell whether orals rebels us, whether the acceptance or the adherence is more as compared to liraglutide, which is once a week, or once a week dulaglutide. But still, in couple of months of practice, I think patient's acceptability is good. The only factor is definitely the cost and few GI side effects, which can come with basically almost all GLP analogs. But right patient selection, I think, is very important. So this is my financial disclosure that I have been commercially supported by Novo Nordisk for today's afternoon talk. So I discussed about role of GLP in management of type 2 diabetes. So any type 2 diabetic drug which is being launched into the market, I think post 2008, FDA also requires that it has to be cardiovascular safe. And we want a drug which has good HbA1c decreasing efficacy, which will not cause hypoglycemia, which has some pleiotropic benefits, and also which will be causing some weight loss, and definitely no weight gain. So I think this is the ideal anti-diabetic drug for type 2 diabetes. So these are our expectations also. So if we see the effects of GLP in human body, you must have seen this slide multiple number of times. But just to be short, I think importantly, GLP analogs act at the level of pancreas by improving the insulin secretion. How do they do it? They improve the cyclic AMP secretion from the pancreatic cells. They activate that cyclic AMP pathway, improving the insulin secretion from the beta cells. Interestingly, simultaneously, most of the GLP analogs, they also decrease glucagon secretion from alpha cells. So that is why it seems to be an ideal combination with, sometimes we say, with SGLT2 inhibitors also, because SGLT2 inhibitors over a period of time can increase glucagon secretion. So good effect on pancreas. They decrease hepatic gluconeogenesis. They have some cardioprotective effect also. Basically, we have an animal data where they have shown that GLP analogs decreased inflammation and they decrease the apoptosis of the cardiac cells. But whether it is being replicated into the humans, I think we are still far away from that. Acting at the level of hypothalamus by improving satiety, yes, most of the GLP analogs have that effect, and they definitely decrease gastric emptying. Patients feel more full. So these are broadly the effects of GLP. But one of the another interesting actions at the level of pancreas, I can say, is that there is definitely human preclinical data, or you can say animal studies, which have shown some sort of beta cell preservation also with GLP analogs. But whatever data we have in humans is that GLP analog, particularly semaglutide, have shown that they improve the pro-insulin and insulin ratios, thereby implying that maybe they have some beta cell preservation effect also, but only long-term studies will throw light on this aspect. So this was an interesting study, I think, published a couple of years back, Pathway to OADs. It was basically an electronic medical records. It was a retrospective observational study. Patients were already on oral hypoglycemic drugs. There were at least 2 OAs. And various other treatments were added onto this, whether it was insulin, sulfonylureas, DPP4, thiazolidines, or a GLP. Interestingly, this pathway 2 OAD studies showed that proportion of patients who achieved HbA1c target less than 7%, patients who showed significant weight loss, and composite outcomes of decreased HbA1c, discontinuation of baseline OADs like 1 OAD, that was significantly more with GLP analogs. Of course, it was the retrospective observational study, so it has an inherent issues of bias, but they did a propensity matching scoring in this study, and that propensity matching scores removes this sort of bias in most of the retrospective observational studies. But interestingly, among the most effective medications for type 2 diabetes seems to be GLP-1 receptor agonists, which have been shown to reduce HbA1c, body weight, and composite outcomes, and even the pill burden. So we need more and more innovations for type 2 diabetic management. We need those treatments which can offer patients affordability, compliance for the patient, and less injections for the patients, especially in advanced type 2 diabetic patients. So I think oral tablet form is always preferred by the patients. So do we have data with regards to oral GLP? I think yes, there were phase 1 and phase 2 and then phase 3 studies of pioneer studies. But first of all, if we just look how this GLP is working, I think this is the problem with the oral GLP agonists, that they get degraded by the acidic pH of the stomach. They have a very limited bioavailability across the gastric epithelium. So the limited absorption and increased degradation in the stomach. So what they did with semaglutide was that they did a couple of amino acid substitutions, like at 8, 26, and 34. Broadly, by doing these amino acid substitutions at like 8, they made it DPP4 degradation refractory to that. By doing amino acid substitution at 26, they did more albumin binding for this GLP and decreased renal clearance for this molecule. And by doing the amino acid substitution at 34, they prolonged the half-life of this drug. This is having a 94% homology to human GLP. So that's interesting. Why this figure is important? Because if you have a GLP which is quite homologous to native GLP to the tune of around 95%, it is bound to have less immunogenicity. And theoretically also, we have observed very less in studies also any antibodies to this GLP. Because you have some GLPs available in the market which are not human GLP based, which can be exendin based, like lixacenide. So once you have this exendin based GLP, you are bound to have more antibodies formation to the molecule, maybe decreasing the efficacy over a period of time. But semaglutide is a human GLP based molecule and very homologous to the native human GLP. So the scientists, what they did was they combined with this semaglutide oral with SNAC, which is an absorption enhancer. This SNAC, what it does is that increases the local pH, improves the absorption of semaglutide across the gastric epithelium, and prevents its degradation into the stomach. It enhances the oral bioavailability of semaglutide. So semaglutide, oral semaglutide or Rybelsus, is a first-in-class oral GLP-1 receptor agonist. The peak time of its action in the body is somewhere around one hour. Some studies says around 35 minutes to 60 minutes. And the steady state is achieved by somewhere around 4 to 5 weeks with this molecule. Oral semaglutide or Rybelsus has underwent many clinical trials, around 10,000 subjects enrolled. Particularly interesting was phase 3 studies of pioneer trials, which is peptide innovation in early management of diabetes. Pioneer 1, 2, 3, around, I think there are 12 pioneer trials. They have compared Rybelsus or oral semaglutide as a monotherapy with placebo, with active comparators like DPP4 inhibitors, sitagliptin, with empagliflozin, as an add-on to insulin also, and they have compared oral semaglutide with liraglutide and dulaglutide also. So if we just see the summary of Pioneer 1 to 8 as a monotherapy or as compared to sitagliptin or empagliflozin, interestingly, 14 milligram of Rybelsus led on to significant decrease in HbA1c at the end of the treatment. This significance was achieved at different time intervals. If we talk about Pioneer 2 versus sitagliptin was achieved at around 52 weeks. If we talk about Pioneer 3 with versus sitagliptin in Pioneer 3 and versus empagliflozin in Pioneer 2, so the time duration of achievement of this significance was different. In Pioneer 2, where they compared Rybelsus with empagliflozin 25 milligram, the significant decrease in HbA1c was observed at around 52 weeks. They have also studied oral Rybelsus in special patient populations like renal CKD patients, and the baseline GFR was around 30 to 59 ml per square meter body surface area, but there was no significant adverse issues. Of course, we are worried of using GLP analogs in CKD patients with regards to nausea and vomiting, but with Pioneer 5, there were no significant safety issues, and there was a significant decrease in HbA1c as compared to other oral hypoglycemic drugs. If we talk about proportion of patients achieving HbA1c less than 7% at end of treatment, again with Pioneer 2, Pioneer 3, or Pioneer 4 also, where it was compared with 1.8 milligram of liraglutide. Weight, again, it was significantly less as compared to active comparator molecules. Of course, with molecules like sitagliptin, it is bound to have significant results. But interestingly, if we talk about empagliflozin in Pioneer 2 studies, the weight loss was quite similar at around 26 weeks, but this weight loss with oral semaglutide was ongoing till around 52 weeks. And there was blunting of the effect of weight loss with empagliflozin in Pioneer 2 study after around 26 weeks. So I think this was one of the interesting aspects of Rybelsus when we compared this with SGLT2 inhibitor like empagliflozin 25 milligram per day. So across the global Pioneer trials, oral semaglutide achieved weight reduction of around 5 kg. And proportion of patients achieving a body weight loss of more than equal to 5% was higher across the Pioneer studies with Rybelsus. The odds of achieving HbA1c reduction of more than equal to 1% and simultaneously achieving weight loss of more than equal to 5% was again higher in oral Rybelsus across the Pioneer studies. As we know that any new anti-diabetic molecule which is there in the market must have its CV safety data. So whatever results we have with oral semaglutide with regards to CV safety, there are results from the Pioneer 6 study where the baseline population was patients who were more than equal to 50 years of age with established cardiovascular disease at baseline or more than 60 years of age with cardiovascular risk factors. Interestingly, after around 15 months, there were no increased adverse cardiovascular events with oral semaglutide as compared to the placebo, but CV mortality on all-cause mortality was significantly decreased. Whereas if we see the SUSTAIN 6 trial, the cardiovascular superiority of injectable semaglutide was established. I think with the Seoul trial, which is an ongoing trial, that will answer more clearly whether the CV safety data with regards to MACE outcomes, they are superior with oral semaglutide as compared to the placebo. So the change in HbA1c and body weight was definitely encouraging with oral semaglutide, and we have a pooled data from Sustain 6 and the Pioneer 6, which suggest decrease in around 24% major adverse cardiovascular events with oral Rybelsus. So I think oral semaglutide is superior with regards to HbA1c reduction and weight reduction as compared to empagliflozin, daily liraglutide, or daily sitagliptin. The weight reduction seems to be more. The cardiovascular safety, whatever data we have, there seems to be no adverse signals with semaglutide at the moment with regards to MACE outcomes. And overall, if we talk about adverse events, I think most important adverse event is pancreatitis, which can occur with GLP analogs. There were no adverse events seen with this molecule across Pioneer studies with regards to GI problems. Efficacy well established of oral Rybelsus, even in advanced stage of type 2 diabetes.
Thank you, Dr. Samar Agrawal. He has nicely told about the oral peptides, peptide in a pill. To summarize in one sentence, any drug which is released totally is better for treatment of diabetes. Injectable drugs, be it insulin or injectable analogs of any GLP-1 or GLP-2, they are not released totally. So any drug which is released totally works better for a diabetes management. So this is really a game changer. Pill in a peptide, semaglutide, will come into practice once the price is bit reduced for use in the general public. Now I invite questions from the public who have anything to ask to Dr. Agrawal. If there is no questions, we will thank Dr. Agrawal for his excellent talk.
Thank you, sir.
Thank you.
I now request our chairpersons to present the token of appreciation to our speaker, Dr. Sameer Agarwal. I request Dr. Kuldeep Dhar to please come up on stage and present token of appreciation to our chairpersons. Thank you, sir, for such a wonderful session. Moving forward to our last session of this 2 days academic feast, basal insulin in type 2 diabetes mellitus, decoding 2 decades of wall of evidence. I request our chairpersons to please come on stage and grace this last session of the day. Dr. B.S. Pandey, Professor, General Medicine, Sharda University, and Dr. Paras Gangwal, Consultant Physician, East Delhi Medical Center.
Professor Chakravarti. He is a senior consultant physician, unit head in the Department of Internal Medicine and Diabetology, Critical Care in the Metro Multi-Specialty Hospital, Noida. He is also professor in ESI Government Medical College. He is a chief editor, Journal of Internal Medicine, Walter. Founder member and chairman and ex-secretary API Noida chapter. Organizing secretary of UP API 2015. Organizing chairman Noida API 2017-2018 and WCC 2022. Principal and co-investigator of various clinical projects, national and international publication. Number of the national and international publication are in his credit. He is awarded as guest of honor for outstanding contribution and dedication to the service of mankind. Awarded with Professor B.C. Bansal Oration Award and number of the award as an honorary and distinguished service. And on behalf of myself and all colleague and medical fraternity, I congratulate him for being President-elect for UP API.
Thank you.
Over to Dr. Chakravarti to deliver his talk. Oh, all right, all right. So I think basal insulin is one of the wonderful innovations as far as the diabetes management is concerned, breaking the patient ideology of injection therapy. I think it is best initiated with the basal insulin because the ease of initiation with one single dose is probably something which is wonderful. And we'll listen from Dr. Chakravarti how the things have been in the last 2 decades with this part of the therapy. Dr. Chakravarti, I think you can begin with some general information then.
Good afternoon. I being the first as well as the last batsman of the whole in the whole cricket ground. I thank first of all Dr. Amit, Dr. Saurabh, Dr. Amitesh for this wonderful conference which they have arranged and wish them the same success every year to come. So since the topic is basal insulin, I think all of us have been using basal insulins for quite a long time. Now we have sufficient experience and is able to distinguish between the differences what we got, what we used to prescribe as an NPH, and now followed by the different analogs which we are using, the glargine 300, the degludec, all those which we are using now. We now note that there is a sizable difference between the previous generation and the newer generation. One of the most important thing in the whole aspects of basal insulin is the duration of action. Most of these newer basal insulins definitely works for more than 16 hours at least, and some of them works up to 36 hours. So it is an important proposition that we continue to have the basal effects for a very long time. Long time definitely helps us in controlling in two ways. We always try to fix the fasting first. So whenever we are prescribing any insulin, we need to fix the fasting first. And with NPH, we were not able to do the same. With NPH, the action finishes at the most 12 to 14 hours, whereas with newer basal insulins, this action remains for a longer duration. And whenever we are prescribing it at night, the action do persist till morning. So definitely we are much more convenience of controlling the sugar in a much better way. I will not bore you for long. It's a last lecture, but certain points I would like to highlight, and I would also give you the highlights of the landmark trial, which almost summarizes our topic, diabetes in Indians, how different we are. So based on the exact theme, the whole concept of landmark was set up, and the trial of, I'll give you just 1 year data, but the summary of it, I will tell you what exactly we have got and how the things are going ahead in India in terms of diabetes and its comorbid states. So the basal insulin decoding 2 decades of evidence. Now we have almost experience of 2 decades. So desirable attributes, what we are asking for from the basal insulin, it has to be ideal and the therapy should have a long duration of action, as I told you, and relatively flat, consistent insulin concentration and profile over time. And intra-patient variability. Yesterday I was talking about the glycemic variability and what are the various ways we can reduce this glycemic variability. So insulin is also one of them, where this basal insulin is taking care of this variability, especially the newer analog ones. Many of the patients will ask you, because of the cost factor, that can I use the older one? This is available in CGHS. This is what are being given in ECHS. So it is all right. You may not be able to justify with the ECHS or CGHS doctor that why are we using it. But there is definitely a significant difference in the time action profile of these drugs, that the variability it is taking care for. So the glycemic variability is an important part in our day-to-day practice, and it should be easy to administer and should have a favorable safety profile in terms of the hypoglycemia. So pre-basal analog era was NPH, and now we have better insulins like insulin glargine and others as well. So all these newer insulins are taking care of all these profiles, the long action, the variability part, and have a good safety profile as well. So as I told you, we have to fix the fasting first. So we are fixing. In fact, if you see the higher HbA1c and greater fasting in patients with in Asian populations is what we observe. And a fasting blood sugar more than 7 millimoles per liter is an independent risk factor for mortality in patients with COVID-19. Glycemic targets achieved with basal insulin, despite having high basal HbA1c, we have a 2 decades of evidence now. Now we can easily say, yes, we can fix the fasting first with the help of these newer molecules. See, there are so many trials which has been conducted and all of them have shown a significant reduction of HbA1c like 1.579 up to 2 HbA1c reduction is possible. So we need a holistic blood glucose control. We do not want an elevated fasting sugar. We want this to be removed. And we know if the fasting is well controlled, the PPG will also come down as well. So we need to fix the fasting first. The basal insulin provides a holistic glycemic control in the real world scenario. So I was mentioning about this landmark trial. I'll come to the summary of that trial later on. So this trial has definitely showed us how the basal insulins do control in a holistic way. Basal insulin, as we are seeing in various guidelines, the HbA1c guidelines and the ADA, as well as in the RSHDA guidelines. The ADA guidelines definitely says that you have no scope of premix. They are more interested in the basal insulin. The guidelines are unanimous in recommending basal insulin at initiation. So if the OHA fails, what are you going to give? Premix or basal insulin? The vote is always in favor of basal insulin. You can see the IDF, RSSDI, AAC, ADA, all are showing that even the DID2022 guidelines recommend basal insulin as the most convenient initial insulin regimen. So what are the actual benefits? The basal insulin analogs are the simplest and most convenient option, preferably to initiate the person on basal insulin during personal consultation. And even during the COVID times, we did use basal insulins on phone. So that is the safest one. In other insulins which you are using, you will always worry whether the patient will go into hypo or not. But with basal insulin, chances of that hypoglycemia is much less. And the starting dose is relatively fixed, and you can use it to start with. You can use 10 units per day. Even in the hospital also, on phone also, you can order, okay, 10 unit de do. So, and the 0.1 to 0.0 units per kg per day is the usual dose. And let us see what the evidences we have. There are plenty of evidences we have which says the efficacy of the drug, the reduction in the glycemic variability, glucose lowering efficacy, and the various meta-analysis also shows there is a significant glucose lowering efficacy in this particular trial, the Hong et al., which has shown that there is no statistically different HbA1c change from baseline in patients using basal as well as premixed insulin. However, the chances of hypoglycemia is much lower with basal insulins. And there are various co-formulations. So we have given various CMEs regarding the co-formulation, that these co-formulations are better. Here also, greater fasting reduction has been observed with glargine 100, and there is a comparable HbA1c reduction. As you can see, there is a comparable HbA1c reduction in both. So you cannot say this particular is superior to the other. So we are, and the second comparison was also done from second generation to first generation basal insulin. There also it has shown that the both have a significantly HbA1c rolling capability. So here, what exactly are we achieving with basal insulin? There is a basal insulin helps in maintaining optimal time in range. So yes, yesterday we were also discussing how can we keep this sugar within range. So basal insulins can keep more than 70% time maintained within range, 70 to 180 with this basal insulin. 8 to 9% time below 70% with basal insulin. So which is very significant that you are able to keep the sugar within control for a longer duration. So we can also see the safety. There are various aspects of the safety. And if you compare premixed BD twice daily in patients inadequately controlled on OADs, the lack of trial, overall 50% there is a lesser risk of overall symptomatic and nocturnal hypoglycemia as has been noted with glargine. Glargine 100 plus OAD versus premixed insulin twice daily in type 2 diabetic patients inadequately controlled on OAD. So the durable study was conducted and it says that there is a 25% significant overall hypoglycemia rate in this when we are using the glargine 100. So basal versus co-formulation, we have all compared it. And if you compare with the safety consideration or the weight gain, there is a 36% lesser weight gain with glargine 100 at 52 weeks. If you further compare with the in terms of hypoglycemia, glargine 300 has a lower rate of anytime or nocturnal hypoglycemia, and IDEG has a lower rate of nocturnal hypoglycemia only. So there is a difference between these two. Treatment satisfaction is also another very important thing. Treatment satisfaction in terms of the injection, we can use safely. In terms of the pen, we can use. The treatment satisfaction in insulin naive patients is significantly higher with insulin glargine compared to the premixed insulin. And glargine 100 improves the patient satisfaction in terms of safety, convenience, and efficacy. All these three are improved with the help of with insulin therapy, even patients with, if you compare this with premixed insulin. So overall, whatever we have got all the information that these are safe, these are being used at various places. The in the nighttime hypoglycemia, nocturnal hypoglycemia is less. All this now we have combined, and now let us see what exactly is a shift of our practice overall. So two major studies were conducted. One is a dive care study, and the second one is a landmark study. This is still an ongoing study, and the third year data has about to be released shortly. So in this particular study, the overall, whatever it has been summarized in this particular slide, and is probably the take-home message of the whole conference as well. So landmark is the first of its kind, prospective, because all other was cross-sectional studies, all those dive care study and ICMR in dive study, all those were cross-sectional study. But this is a longitudinal, real-world study conducted nationwide. All other were very localized studies or some centers they were, but this was conducted throughout India. Many of us are part of it in this landmark trial. Average age of diagnosis of diabetes is 43 years. So this is important. So the average age of diagnosis in this real world, what has been noted is 43 years. And 80% are overweight or obese. And you say that we are not. And yesterday also one slide we showed that there is an increased caloric consumption from 2000 no, from 1965. The data was from 1965 till 2000. There is a 2022. There is a marked increase in caloric consumption from Indians. So definitely we are eating much more than what we were eating earlier, and 80% are overweight or obese. There was an average fall of 0.5% from baseline HbA1c of 8.1% at 1 year. So, this average fall 0.5%, is it different from Western population? It is almost the same. So, we are not doing that bad. We have all the medicines which are available, which are needed for the control of the disease are there. Biguanides and sulfonylureas were common OADs used and increased in uptake seen with DPP4 and SGLT at 1 year. So that means majority of the doctors who are prescribing the drugs are sulfonylurea and metformin. Still now nobody is prescribing DPP4 or the SGLT2 inhibitor right at the beginning. So this is a trial which is there throughout India. That means people are still using biguanides and sulfonylurea still. And after 1 year, if the sugars are not keeping under control, then they are going ahead with SGLT2 or DPP4 inhibitors. Basal analog and the human premix were common injectable used. Still, now you can see, still term is coming. Still we are using human premix and basal analogs. Now they are coming. Human premix are being used still, and RSSDI still endorses, which not in conformation with ADA. So they are still using human premix and basal analog. Both were commonly used. No additional benefit adding more than 3 OADs. So if you have to keep a sugar under control, you just cannot go on adding more than 3, 4, 5, because we have now fifth choice as well. So still we cannot simply go ahead. The glucotoxicity in any case will remain. So you need to bring down the sugars after 3 OAD. No, it is better to add basal insulins. Neuropathy was the most common complication noted. Every patient coming to your OPD, पैर के नीचे झंझनाहट हो रहा है, everybody will say the same. So the neuropathy, definitely people are developing a lot, and we need to take care of the neuropathy. No neuropathy topic was kept in this whole conference. Participants from the non-metro cities have higher microvascular complications. Participants from the non-metro cities had higher microvascular complications compared to the metro cities. Why this is so? But this is an observation that the microvascular complications were less. that this is 1 year data. Now 3 year data is also coming. The company will come up with the 3 year data as well. But whatever information we are seeing, we are yet to change our prescriptions according to time. But yes, it is on the way. So to summarize, basal insulin, what we are using is more physiological. We should use it more. Established glucose lowering efficacy has been seen over last 2 decades. The fasting sugar less than 126 associated with better COVID outcome, and it was very easy for us to, even on phone we could prescribe basal insulin, so the advantage was definitely there. And simple and convenient regimen, you can start with 10 units and proceed further. Fasting plasma glucose major contributor to dysglycemia at high A1C. Different studies have already proven it. Lower FPG mitigates PPG excursion. Yes, once you reduce the FPG, definitely the PPG also comes down. The basal insulin preferred for insulin initiation during COVID epidemic, and the guidelines recommend initiating basal insulin of type 2 DM at various guidelines which are saying the same thing. I thank you very much for your kind listening, and please remember the landmark messages.
I think it was a wonderful talk by Dr. Chakravarti on importance of basal insulin. We all know the liver works like यज्ञ में जो आहुति देते हैं ना, कि लौ जलती रहेगी. It's causing gluconeogenesis always. It's always pouring glucose into the blood, whether you are sleeping, eating, or whatever you are doing. So even in our fasting state, we have the gluconeogenesis, which is making your sugars higher. So this basal insulin is a wonderful concept that it lowers your whole glucose curve by whatever point you want to bring it down, 30 points, 40 points, 50 points. So if you find both fasting high, postprandial high, then it is very easy to prescribe that you bring the curve totally down. Whatsoever oral anti-diabetic drugs patient is on, just add a basal insulin, the whole curves gets down. And then second concept of fixed fasting first, I think is best achieved with basal insulin. So I think we should be more in practice of prescribing insulin. So I'll raise one question that when initiating insulin, sir, how do you actually decide that I'll be okay with basal insulin alone, or would should I begin with the premix insulin, which will take care of one prandial component also and basal component also? Because I am always in a dilemma.
Right.
That I prescribe one pan to the patient, and after some days I say that, look, your prandial is also not controlled. I'll need one more. So would you be okay using a premix insulin taking care of basal and one prandial component of one meal, or how do you take your call on that?
Right. So once a person fails on the OHA, as per the guidelines, definitely the basal insulin needs to be started. We are taking care of the fasting with the help of basal insulin, and the oral agents are taking care of the postprandial part. But many a times, as you rightly said, the control may not be adequate. In that case, we proceed to the next stage, the basal plus. You add the insulin to the next stage, the highest carbohydrate meal. Let it be lunch, let us say. You can add another injection to the lunch. If it is not controlled still, then you go for the basal bolus regimen. Try to withdraw all those drugs which are causing hypoglycemia like sulfonylureas. You can continue with the metformin DPP4 inhibitors and continue with the basal insulin as well as the bolus one. Second aspect that you are saying, let us start with the premix. Yes, the newer co-formulation which has come also takes care of the basal part as well as the prandial part. You can initiate with the co-formulation, and it has been seen in the various studies that the effect, the HbA1c reduction as well as the duration of action and safety profile is almost the same. So definitely that thought is also coming, though it is not in the guideline. So that is also another way of starting. You can use the co-formulation which controls the postprandial, immediate postprandial and the fasting as well.
From audience, yes, you can.
So
because most of the doctors speakers say Degludec. Yesterday I heard one of the speaker telling Glargine 300 is better. So what do you say about it?
So if you start with a, let us consider two aspects. One is the initiation of the insulin, and the second, you are continuing with the insulin for long. If you are considering the patients, you have to again the individualize the patient, what you exactly desire for that particular patient. If you find the patient's overall lifestyle is not very good, the patient is unable to give injections at the right time every day, Degludec is the choice. If you are using the Glargine 300 and whenever you are using, the chances of early anytime hypoglycemia with Glargine 300 is quite less. If you initiate the insulin with 300, initial 3 months, usually a person who develops hypoglycemia do not carry on with the insulin and it becomes very difficult to prescribe further. So those are the patients whom you can go ahead with the insulin glargine where the chances of hypoglycemia are less. So you need to individualize these patients which way you want to prescribe. Both are different choices. Both have prolonged duration of action. Degludec much more than what insulin glargine is there. So you cannot simply tilt towards one insulin.
So you mean hypoglycemia in Glargine 300 is more than the Degludec because of its long half-life?
No, no, no. No, it's not that. The initial period, the hypoglycemia can be there, but with Glargine, yes, it is less.
We are talking about only Glargine and this Degludec, but nobody is talking about the Detimer. Is it because of the low half-life?
Low half-life,
Detimer?
twice daily is a must. Beyond that,
Twice.
because after all, what are we desiring for from the basic? We are desiring that the action must be prolonged. That is why the insulin Glargine was acting up to 16 hours, 16 to 24 hours. But the newer, this one is acting up to 24 hours, Glargine 300.
So Detimer has become obsolete now, or is it indicated in any condition?
It's
almost it will depend on if somebody has a profile like somebody is having fasting high, but his pre-lunch, post-lunch, pre-dinner, post-dinner are pretty well maintained. So you'll have a space for Detamir there because you want to take care of that curve for 14 hours down. Rest is already stable. So there. Pre-lunch is higher, then you can settle very well with Degludec. So it depends the profile of the patient.
You have prescribed in any patient?
Yeah, we have.
Like
earlier
now these days it has become lesser.
Yeah.
These days it has become
Previously
surely lesser.
Previously.
But it doesn't say that it's an obsolete drug. It would have an indication because in final game it comes that every insulin prescription that you prescribe, we have to know time of onset, peak timing, and duration of action. And it has to finally match practically what are you gaining. Are you able to fix all those 7 points? Are you able to fix that glycemic variability without causing much hypo? So that time in range concept is what is beautifully done, with which insulin would depend on the duration of action, peaking, and
So another
the
problem
time that
was
it
the
goes
number
off.
of injection. 5 injections with this. 2 you are giving for Detamir and another 3 for if you are using basal bolus.
Thank you.
And good thing about basal insulins is that they are easily used with oral antidiabetic drugs, even when sulfonylureas are on board. But if you have basal bolus therapy, that is a tough time that you cannot have probably sulfonylureas on board easily. Then you'll have tough time. It's only with metformin, DP4 inhibitors, and SGLT2 inhibitors that you'll be easy mixing insulin with. Basal insulin can go well with sulfonylurea also. But once you are with basal bolus, then sulfonylureas would have probably go off board, which is logical also. Your take on that, sir?
Definitely. Yeah. We are not.
Sir, the bolus have this time duration up to 36 hours. So can be given alternate days?
The datim, this degludec you are talking.
So can it be given alternate days?
Yes, it can be, and various studies it has been shown. However, if you give like that, the erraticness of the sugar and the time in range is not adequate. So it is better to ask the patient, otherwise patient themselves forget sometimes and no insulin is being given. So the company also and the guidelines also, they do not endorse this fact that you give it alternate day.
In that case, there will be no accumulation because of the life that 24 hours or 36 hours life.
Okay. If you see, whenever we are initiating with degludec, you may not get the desired effect on right day 1, day 2, day 3. What happens if you go on giving the drug every day? There what is called a stacking effect. There is a stacking effect which happens. The cumulative dose gradually gets accumulated and then you start getting the desired effect. So that is the reason if you are using it in critical care settings, you may not sometimes get the desired effect. Whereas this fact is not there with the glargine.
So any question from audience? Any question? Then excellent presentation, Professor Insulin. And I think we are united with your presentation. Thank you very much.
Thank you, sir. Thank you. Thank you.
Thank you everyone for a wonderful last session on this day. Now I request our chairpersons to please present token of appreciation to our speaker, Dr. Saibal Chakravarti, sir. I now request Dr. Saurabh Srivastava to please present token of appreciation to our chairpersons. Thank you, sir. I would like to hand over the dais to our organizing secretary, Dr. Amitesh Agarwal, for the valedictory session. So please come on stage.
अरे यार और दिशा है आ जा भाई अमतेश